Hi, welcome students to this live session of Obs and Gynae, where I'll be telling you all the important points about all the important topics and important points for Obs and Gynae before you appear for your NEET 2019 exam. So this will be a mini booster of Obs and Gynae, and for the next 3 hours you will be glued to your mobile screens. So be sure that you have enough stationery with you. Be sure that you have things to munch on or water with you, right? Because you're not going to get up for 3 hours now, right? So the first question on your screen here is question number 1. According to Negley's rule, calculate the EDD of a patient with LMP 9/1/2017, 9th January 2017. Now, whenever you get questions like these, we know that if you have to calculate EDD, you will have to add 9 months and 7 days, because that is the duration of pregnancy, and this is the Negley's formula, right? So when you have to calculate the EDD to whatever month they have given you, you are going to add 9 months to it, right? Either you can count 9 months forward or you can count 3 months backwards, right? Because 3 months backwards become a little easier, a little quicker. So from 9th January, so here it is January, to January, if you are going to add 9 months, you are going to come to October. Or from January, if you are going to subtract 3 months, count 3 months backwards, December, November, October, again you come to October. So that is how you calculate the month of delivery. As far as the date of delivery is concerned, whatever date is given to you, you will always have to add 7 days. Don't get confused that whether I have to add or subtract, nothing doing. Always you have to add 7 days, right? So here 9th January is given. So to 9, you are going to add 7. So that makes it 16th, right? So the EDD of this person, this female, is 16th October 2017. Clear? Always add 9 months, or you can subtract 3 months and always add 7 days. Now this is if the female's cycle were of 28 days. But suppose a question comes to you like it came in JIPMA. A 22 weeks primigravida had her LMP on June 10. Okay, she had 32 days cycles prior to her EDD. Prior to that, her EDD would be. Now, in questions like these, where they are telling you that the cycles are not of 28 days, what you have to do is you have to calculate EDD like you do for normal cases, right? So normally, if this question would have come to you, that it is 10th June, right? So how would you have calculated the EDD? So to June, you have to count 3 months backwards, right? So that brings you to April, May, April and March, right? So I know the month in which she is going to deliver is March. To 10, I am going to add 7, so that is 17th March. Now this 17th March would have been the EDD if her cycle would have been of 28 days. Now since they are saying cycle is 32 days, what I'm going to do is whatever the length of the cycle is given to me, right? I am going to subtract that from 28. So 32 minus 28, that brings me, that is 4. So whatever EDD is there, you will add 4 to it, right? So if the cycle length is longer than 28 days, whatever is the difference between the cycle length and 28 days, you are going to add that to the EDD, right? So 17th March, you are going to add 4, that comes out to be 21st March, right? Now, just in case the question said that the cycle length is 26 days, then what I would have done? Again, I would have calculated EDD like we calculate normally, and then from 28, I would have subtracted 26, and that difference is 2 days. So the length between the cycle and 28 days here is 2 days, right? Now this 2 I will subtract from the EDD. So if the cycles are shorter, whatever is the difference between the cycle length and 28, you will subtract it from the EDD, right? So if it would have been 26 days, then the EDD would have come out to be 17th March minus 2, that is 15th March, right? So this is how you calculate the EDD if the cycle length is not 28 days. And that is also what I have written. Calculate EDD if the cycle length is not 28 days. Calculate EDD as above. If cycle is more than 28 days, you have to add the difference. If cycle is less than 28 days, you have to subtract the difference. Right? So that is how you calculate the EDD. Okay, next question. A 35-year-old female has twin pregnancy at 22 weeks. She has previous history of 2 abortions and she has a 5-year-old child born at 38 weeks. Her gravida and parity is. So, very important to know what is gravida and what is parity. Gravida is the number of times a female has conceived, and whenever you are telling gravida, in gravida you are always going to include the present pregnancy. That is one thing which you have to keep in mind. Always in gravida, if the female is presently pregnant, you have to include the present pregnancy when you are telling the gravida of a female, right? Now, as far as parity is concerned, parity is the number of pregnancies which have gone beyond the period of viability. Now, as far as parity is concerned, parity is the number of pregnancies which have gone beyond 20 weeks of pregnancy. So, here you have to remember that any pregnancy which has gone beyond 20 weeks will be calculated in parity. If the pregnancy ended before 20 weeks, in other words, if a female had an abortion, right, then you are not going to calculate that in parity. That's number one thing which you have to remember. The next thing which you have to remember when you are telling the parity is that present pregnancy is not included in parity, right? That's the second thing which you have to remember about parity. And third thing what you have to remember is if they are talking about twin pregnancy, see, twin pregnancy or triplet pregnancy, all of them are considered as a single pregnancy, right? That single pregnancy did result in 2 children, right? But it is counted as a single pregnancy, whether you are counting gravida or whether you are counting it in parity. Always twin pregnancy is counted as a single pregnancy, right? So this is what you had to know about gravida and about parity. And to clear all your confusions about parity, right, this is an extract from Williams which says parity is determined by the number of pregnancies reaching 20 weeks, right? So if the pregnancy goes beyond 20 weeks, it is counted in parity. If it is less than 20 weeks, it's not counted in parity. It is not increased to a higher number if multiples are delivered in a given pregnancy. Moreover, stillbirth does not lower this number, right? So I hope now you don't have any confusions regarding gravida and parity, right? Now, how can you write gravida and parity? See, there are 3 ways of writing gravida and parity. The simplest way of writing gravida and parity is where gravida is represented by a single number and parity is represented by a single number, right? That's the easiest way. So this is here where gravida is represented by a single number and parity by a single number. The second way is where gravida is represented by a single number but parity is represented by 2 numbers. Now, when you are representing parity by 2 numbers, the first number is the number of pregnancies which have gone beyond 20 weeks, right? Or 20 weeks or beyond 20 weeks. The second number is the number of abortions. As I told you, the definition for abortion is all those pregnancies which end at less than 20 weeks, right? So, you will have a number. So, suppose if parity is P1 plus 1. What does that mean? That means one pregnancy, this female's one pregnancy went beyond 20 weeks and one ended in an abortion, right? Then, the latest method of writing gravida and parity is where parity is represented by 4 numbers, right? A, B, C and D here, where A stands for the number of term deliveries, right? B stands for the number of preterm deliveries, right? Then the third number is going to stand for the number of abortions and the fourth number stands for the number of live births, right? So it is A plus B plus C plus D. A is the number of term deliveries, B is the number of preterm deliveries, third number, that is C, is the number of abortions and D is the number of live births. Now this method is called as the GT-PAL system. So it's very easy to remember like this. G is for gravida, T for term, P for preterm, A for abortion, L for live birth, right? Now this is what the question was based on, the GT-PAL system. So let's go and check our question. The question is saying a 35-year-old female has twin pregnancy, right? So she is just now pregnant and she has a twin pregnancy at 22 weeks. She has previous 2 history of abortion. So just now she is pregnant. She has 2 history of abortions and she has a 5-year-old child, right? So the gravida of this female is 4. She is a 4th gravida female, right? This is her 4th pregnancy, right? Now, let's talk about parity. Now, in parity, first number stands for the number of term deliveries. Now, the question is telling you that she has a 5-year-old child who was born at 38 weeks, right? So, that is 1. Term deliveries. Preterm deliveries. Now, what do you understand by preterm deliveries? Preterm deliveries means any delivery which is happening at less than 37 weeks. So, in this case, no delivery is happening at less than 37 weeks. So, it is 0. Right? The third number is the number of abortions. The question is telling you she has 2 abortions plus. Next is the number of live births. So, the number of live births, she has 1 child. So, the answer to this question is G4, P1 plus 0 plus 2 plus 1. So, that is how you represent gravida and parity by the GT-PAL system. Clear? Now, since we were talking about abortions here, let's do a question of abortions now. A lady comes to gynae OPD for preconceptional counseling with history of 2 second trimester abortions. What is the next investigation you will advise? So before I tell you the answer to this question, let us discuss quickly about abortions. Now, what is abortion? Just now I told you abortion is any pregnancy which is ending at less than 20 weeks. According to WHO, abortion is any pregnancy which ends at less than 500 grams when the weight of the fetus is less than 500 grams. What you have to remember here is that at 20 weeks, the weight of the fetus is 300 grams, right? It's not 500 grams at 20 weeks. Clear? Now, the next thing is, so many times you read in the ultrasound reports that it is a case of blighted ovum. So, what is a blighted ovum and how do you differentiate it from missed abortion? See, blighted ovum means that in that female, when an ultrasound was done, the gestational sac was seen. But in the gestational sac, there wasn't any yolk sac, there wasn't any fetal part, there was no cardiac activity, right? So, if you are seeing just a gestational sac, right, and if the diameter, the mean sac diameter is more than equal to 25 millimeters, and still you are not seeing any yolk sac, you are not seeing any cardiac activity, you are not seeing any part of any fetal tissue also. That is what is blighted ovum, which means that if you are getting a gestational sac which is smaller than 25 mm, right, you will keep on repeating the ultrasounds till the gestational sac becomes 25 mm, and still if you do not see any evidence of fetus, then you are going to call it as blighted ovum. Before 25 mm, you are not going to call it as a blighted ovum. The other thing is missed abortion. Missed abortion means that the gestational sac is present, the yolk sac or the fetus, some part of the fetus is also present, the fetal tissue the fetal pole is present, but there is no cardiac activity in the fetus, right? Now, when am I going to call it as a missed abortion? I'm going to call it as a missed abortion when the crown rump length is more than equal to 7 millimeters and still I am not getting any cardiac activity. Then I'm going to call it as a missed abortion. That's very, very important. The next very important point which we are going to quickly revise is what are the causes of abortion. Now, the most common cause of first trimester or second trimester spontaneous abortion, if they ask you, you know it is chromosomal anomaly. And the best answer is that it is the most common chromosomal anomaly which leads to abortions is aneuploidy. If aneuploidy is not given, then you are going to say that the answer is, second best answer is trisomy. If trisomy is also not given in your options, then you are going to mark the answer as monosomy X, right? Now, if monosomy X is also not given, then you are going to mark the answer as trisomy 16. Clear? This sequence we have done in the classes of Obs and Gynae also, which I have taken in my book also, and we have done all this in the Marrow app as well, right? Now, another thing what I want all of you to remember is that if they ask you what is the most lethal trisomy, again you are going to say that the most lethal trisomy is trisomy 16, right? But if they ask you which is the most viable trisomy, the most viable trisomy, all of you know, that is Down syndrome, that is trisomy 21. Now, the most important risk factor for spontaneous abortions is advancing maternal age, right? And the second most common risk factor is previous history of abortion. So that's the most common risk factor for abortions, right? That was about spontaneous abortion. The other thing about spontaneous abortion which you have to remember is that infections, yes, they can lead to spontaneous abortions. Now, let us talk about recurrent abortions. Now, in recurrent abortion, first thing is, what is the definition for recurrent abortion or a recurrent pregnancy loss? The recurrent abortion is if there are 3 or more than 3 consecutive pregnancy losses, then that is called as a recurrent abortion. Now, investigations for recurrent abortions, they should begin whenever a female has 2 or more than 2 abortions, then the investigations should begin. Now, the most common cause for recurrent abortions is uterine abnormalities. Please, it is not APLA. Right? It is uterine abnormalities, and these uterine abnormalities, they could be in the form of cervical incompetence, they could be in the form of a fibroid, they could be in the form of malformations, the congenital malformations, right? What you have to remember is the most common congenital malformation which can lead to recurrent abortion is a septate uterus, and the most common fibroid which can lead to recurrent abortions is a submucous fibroid. Now, in order to document my answer, I have this text here. Right, so here it is written that the uterine factors, the acquired and the congenital uterine abnormalities, they are responsible for 10 to 50% of recurrent pregnancy loss, right? So please, you are not going to mark the answer as APLA if you get what is the most common cause of recurrent pregnancy loss or recurrent abortions. Here in the same text it's written antiphospholipid syndrome, it accounts for 5 to 15% of patients with recurrent pregnancy loss, right? So the most common cause for recurrent abortions is uterine abnormalities. If uterine abnormalities is not given, then you are going to say it's APLA, antiphospholipid antibody syndrome. The third most common cause is the endocrine causes, in which one of the major one is hypothyroidism, and then chromosomal anomalies. Chromosomal anomalies, they are accounting for only 4% cases of recurrent pregnancy loss. And the most common chromosomal anomaly which leads to recurrent pregnancy loss, do not say it's aneuploidy, right? The most common chromosomal anomaly which leads to recurrent pregnancy loss, that is balanced translocations of chromosomes, right? The other very important point which you are not going to forget is that infections, they do not lead to recurrent abortions, right? So if they, now coming back to our question, and the question was, a lady comes to gynae OPD. So this was the question here. A lady comes to gynae OPD for preconceptional counseling with history of 2 second trimester abortions. Now, whenever a female comes to you with history of 2 second trimester abortions, I told you that whenever there are 2 or more than 2 abortions, the investigations should begin. What you have to understand here is that yes, one of the major causes for second trimester recurrent abortions is cervical incompetence, right? In other words, that's a uterine abnormality. But the other thing is that this female is coming for preconceptional counseling. The patient is not pregnant as just now. So if patient is not pregnant just now, I cannot do a TVS to detect cervical incompetence. So TVS is incorrect answer, right? Because patient is not presently pregnant, right? Now, if patient is not presently pregnant, then the ways by which you can detect cervical incompetence, as I have told you, is you can insert a Hagar's dilator, and if the patient doesn't offer you any resistance, then that indicates that yes, there can be cervical incompetence. And second is if you can do a hysterocervicography and if you get a funnel-shaped appearance. But again, they are not very good tests which will tell you about cervical incompetence. Rather, if you read the text here, it says that the diagnosis of cervical insufficiency, it cannot be made or excluded in a non-pregnant woman by any test, right? So in this case, I cannot exclude cervical insufficiency in her. Now, the next thing which I know that in uterine reasons, I mean the uterine causes for recurrent abortions is that uterine malformations, right? And in order to detect uterine malformations, the best investigation is hysteroscopy, right? So the next step over here, what I'm going to advise her is that go for a hysteroscopy. Clear? Then Now, next thing which I want to tell you is, if they give you an image of placenta and they ask you which type of twin pregnancy it is, you should be able to diagnose it by looking at the images. And for that, you will have to understand that twin pregnancy, all of you know, it can be dizygotic or it can be monozygotic, right? And dizygotic is always dichorionic, diamniotic. Right? Now, monozygotic, it always depends on the time at which division happens, which tells you whether it is going to be dichorionic or diamniotic. If division is happening at less than 3 days, that is in less than 72 hours or within 72 hours, then the monozygotic twins will be dichorionic and diamniotic. Now, if you have to draw a twin pregnancy, dichorionic, diamniotic, this is how you draw. This is the fetus over here, which is blue in color, which I am making blue in color. Then over here, this green color, which I am making, is the amnion, right? And then you have the black color is the chorion. Right? Now, as you can see, in dichorionic, diamniotic twins, there are 4 layers of membranes between the fetuses, right? There will be 2 layers of chorion and 2 layers of amnion. In other words, the membranes are going to be very, very thick and they are going to be more than 2 millimeters, right? So, this is how you are going to diagnose a dichorionic, diamniotic twin. Now, look at this image over here, which they have given you. These are the umbilical cords, right? So, this is a twin pregnancy, and when you look here, this is the thick membrane which is present between them, right? So, whenever the 2 cords are separated by a thick membrane, that means it is dichorionic, diamniotic, and this also forms the basis of the twin peak sign on ultrasound, right? So, in twin peak sign on ultrasound, because, so in this image, suppose if over here the placenta was here, the placenta would have come like this in between the 2 chorions, like this, right? And this is what forms the basis of the twin peak sign. If you remember, we have done this in image based session also. So, over here you can see this over here is the placenta, and the placenta is coming in between the 2 twins in the form of a peak, right? This is twin number 1, this is twin number 2. This is dichorionic, diamniotic twin pregnancy. Twin peak sign is also called as the lambda sign, and the best time to detect twin peak sign is 10 weeks. The range is between 10 to 14 weeks, right? So, this was the dichorionic, diamniotic twin pregnancy. Now, if division happens between 4 to 8 days, then you get monochorionic, diamniotic twin. Again, this over here is the fetus. This is one amnion, this is another amnion, and you have the chorion, right? Now, in this case, the membranes which are present between the twins, they are only 2 layers of membranes, right? In other words, membranes will be present between the twins, but they will be very thin. And this is exactly what you see in the next image here. This is one placenta, this is the one cord of the baby, and this is the second cord of the twin, right? And in between over here, I can see a thin membrane. Can you see this thin membrane? I am erasing it. I'll make it with a different color so that you see it. This, a thin membrane. Again, erasing it and showing it to you so that you appreciate the thin membrane, right? Now, whenever you see 2 cords and you see a thin membrane between the cords, that means it's monochorionic diamniotic twin. When you do an ultrasound of a monochorionic diamniotic twin, you will see both the twins. This is, if you see here, this is one twin, this is another twin. But the placenta, this over here is the placenta. The placenta is not coming in between the 2 fetuses, right? So, here the twin peak sign is negative. So, in monochorionic twins, twin peak sign is absent on ultrasound. In dichorionic twins, the twin peak sign is present. So, appreciate the twin peak sign again, right? Now, in case of monochorionic diamniotic twins, the complication which you have to worry about is the twin-to-twin transfusion syndrome, right? The third variety of twins is monochorionic monoamniotic twins. If this monochorionic monoamniotic twins is going to happen if the division occurs at more than equal to 8 days. right? In that case, you will have both the fetuses like this. They will be surrounded by a single amnion and they will be surrounded by a single chorion, right? There will be no membrane between the two. So remember, thick membrane between the two, dichorionic, diamniotic. Thin membrane, monochorionic, diamniotic. No membrane, monochorionic, monoamniotic. Now again, see this image here. This is one cord and this is the other cord, right? But I do not see any membrane between the two. That means it is monochorionic, monoamniotic, right? So this was dichorionic, diamniotic, thin membrane. This was monochorionic, diamniotic, thin membrane. And this is monochorionic, monoamniotic. Now, in case of monochorionic, monoamniotic twins, because both the twins are lying in the same amniotic fluid, there is no membrane separating them. That is why the specific complication of monochorionic, monoamniotic twins is cord entanglement, right? And that is why I have always told you that the management for monochorionic, monoamniotic twins is you have to do a cesarean section between 32 to 34 weeks of pregnancy, right? Very, very important. That's an absolute indication for doing cesarean section. Now, that is what you have to remember about twin pregnancy. In twin pregnancy, the other thing what you have to remember in twin pregnancy is twin-to-twin transfusion syndrome. Read everything about twin-to-twin transfusion syndrome, and the staging for twin-to-twin transfusion syndrome, I told you that is the Quintero staging, right? Now, let's go ahead. So on Facebook, I had got a lot of requests from the students saying that they want all the drugs and dosages of gynae to be at one place, right? Now, before I start compiling all those things for you, let's look at one very important questions, two questions rather. A 32 weeks pregnant female presented with labor pains and minimum vaginal discharge on analysis of the it's not cervicovesical, it's cervicovaginal discharge, showed fibronectin. What is the probable diagnosis? That's question number 5 which has come to you. And question number 6 is, all of the following indicate fetal lung maturity except, right? Lesser than upon sphingomyelin ratio more than 2, positive shake test, increased phosphatidylglycerol, and blue cells in the Nile blue test. So now you know what I'm going to talk about. I'm going to talk about the preterm labor, but we are not going to discuss everything about preterm labor. We are going to make a table for all the things which I'm going to discuss from now on, right? In that table, I want you to make 5 rows. Quickly make 5 rows. On left hand side, the extreme left, the column is the problems column. Then the second column is about the drugs. Third is about the dosages. Fourth is any update which I want to give you. And fifth is the management, right? So the first problem which we are going to discuss is preterm labor. And all of you know that preterm labor is when labor happens at less than 37 weeks. And for preterm labor, the problem is that the lungs of the baby are not mature. Here you have to remember that surfactant secretion, it begins by 28 weeks and surfactant secretion begins by 20 weeks. And by 28 weeks, surfactant is present in the amniotic fluid, right? Now, lungs of the baby, they start maturing by 34 weeks and finally they are mature by 39 weeks. Now, the drug which can be used for accelerating the lung maturity is the glucocorticoids, and in glucocorticoids, we have 2 very important drugs, betamethasone and dexamethasone. Now, the dose of betamethasone for maturity of lungs, please write it down. That is, you have to give 2 injections, 12 mg each, 24 hours apart, right? Whereas the dose of dexamethasone is you have to give 4 injections, 6 mg each, 12 hours apart, right? Now, these 2 dosages, they are very, very important dosages. Another thing what you have to remember about corticosteroids is that corticosteroids, they need at least 24 hours to act, and the contraindication for corticosteroids is chorioamnionitis. Now, the update which I want to tell you here is, now the update over here is, how do you define preterm labor, or how do you diagnose preterm labor rather? Now, for the diagnosis of preterm labor, a female should be having more than equal to 4 contractions in 20 minutes. So, if a pregnant female is having more than equal to 4 contractions in 20 minutes or more than equal to 8 contractions in 60 minutes, right? And along with these contractions, any of these 3 should be present, which I'm going to tell you. Number 1, the cervical dilatation should be more than equal to 3 centimeters, right? Number 2, so cervical dilatation more than equal to 3 centimeters, right? Number 2, length of the cervix less than equal to 2 centimeters. That's number 2. And number 3, if cervical length is between 2 to 3 centimeters, In that case, fibronectin should be present. So I'm repeating, quickly jot it down. Preterm labor, for the diagnosis of preterm labor, a pregnant female should be having more than equal to 4 contractions in 20 minutes or more than equal to 8 contractions in 60 minutes along with any of these 3. Number 1, the length of the cervix should be less than 2 centimeters. Dilatation should be more than 3 centimeters. Length of the cervix less than 2 centimeters, right? And if the length of the cervix is between 2 to 3 centimeters, then fibronectin should be present, right? Now, fibronectin, this is a protein, it's an extracellular matrix protein which is present in the interface between the chorion and the decidua, right? And whenever this interface gets disrupted, right, due to any reason, that reason could be a uterine contraction, that reason could be abruptio placenta, that reason could be infection, then this fibronectin protein, it will be detected in the cervicovaginal discharge, right? And in order to say that yes, fibronectin protein is present, it should be more than equal to 50 nanograms. Then we are going to say that yes, it is present. Now, because corticosteroids, they need 24 hours to act. That is why whenever you have to give corticosteroids and in case patient is having contractions, you will have to add a short-term tocolytics. We will talk about tocolytics shortly. But before I change the slide, let's see how preterm labor is managed. Now, for the management of preterm labor, if patient is more than equal to 34 weeks, now because after 34 weeks, the lungs of the baby start maturing, that is why after 34 weeks, we do not give any corticosteroids and we wait and watch. The only thing what you have to do is you have to take out vaginal cultures, vaginal swab and send it for culture in order to detect group B streptococci, right? Now, ACOG says that you should give 1 dose of corticosteroid, that is the full course of corticosteroid, even if patient is more than 34 weeks and she goes into labor. But these recommendations of ACOG are still recommendations. They are not being followed anywhere, right? So as far as preterm labor at more than 34 weeks is concerned, we do only wait and watch and we are going to check for group B streptococci infection. That's it. Now, if preterm labor happens at less than 34 weeks, in that case, you have to give corticosteroids and you have to give tocolytics because corticosteroids, they need 24 hours to act, and you are going to give magnesium sulfate. This magnesium sulfate is going to act as a neuroprotective agent and will protect the fetus from cerebral palsy, right? Now, again, before I change the slide, one more very important point. What is the most common risk factor for preterm labor? The most common risk factor for preterm labor is previous history of preterm labor, right? Now, in all those patients who are coming to you with previous history of preterm labor and just now the contractions have not begun, right? You can prevent preterm labor by giving them progesterone, right? And you can do a cervical cerclage. Now, this cervical cerclage which you are going to do, it is the same cervical cerclage which you do in cervical incompetence. Cervical cerclage, whether you are doing in cervical incompetence or whether you are doing it in preterm labor, you can do it by abdominal method or you can do it by vaginal method. Vaginal is the most commonly used method, in which the most commonly used technique is the McDonald cerclage. McDonald cerclage. Now, in McDonald cerclage, if you remember, I have told you in class also and in Marrow also, you are going to give purse string sutures. These purse string sutures, the material, the suture which you are going to use here should be a non-absorbable suture, and this suture is given at the level of internal os. In case of cervical incompetence, cervical encerclage is done around 14 to 18 weeks of pregnancy, right? Now, whenever you do a cerclage, you will also have to remove the stitch. The removal of the stitch will be done at 37 weeks, right? Now, in case of preterm labor, when can I'm going to go for cervical encerclage? What is the cutoff length of the cervix which will predict that yes, this female might have a preterm labor? So, two very, very important questions. What is the cutoff length To detect preterm labor on ultrasound, just now I told you, to detect preterm labor, the definition of preterm labor is that the length, patient should be having uterine contractions and the length of the cervix should be less than 2 centimeters. But if you have to predict preterm labor, right, patient is not having uterine contractions, she is a previous history of preterm labor, and you have to predict preterm labor in her. In order to predict preterm labor, the cutoff length of the cervix is less than 2.5 centimeters, right? So if the cutoff length of, if the length of the cervix is 2.5 centimeters or less and patient has history of preterm labor, in that case, I'm going to go for a cervical cerclage, right? So two indications for doing cervical cerclage. Number one is cervical incompetence and number two, to prevent preterm labor. Right? Now, whether it is cervical incompetence or whether it is preterm labor, in both these conditions, when you do an ultrasound, you will see that the cervix appears U-shaped. The normal shape of the cervix is T-shaped, right? But in cervical incompetence and in preterm labor, the cervix appears U-shaped. Why is that? That is because both in cervical incompetence and in preterm labor, the cervix dilates. Now, all of you know that as the cervix dilates, it becomes shorter. So, it will appear U-shaped cervix, right? Now, let's talk about, continue your table, let's talk about the tocolytics. Now, best tocolytic is nifedipine. Now, whenever you have to give nifedipine as a tocolytic, you are going to give 20 mg orally stat, right? And after that, you are going to give 10 mg after every 4 to 6 hourly. And once the contractions stop, you are going to give a maintenance dose, and that is 10 mg 8 hourly for 1 week. So, start dose is 20 mg followed by 10 mg, and then 10 mg is also the maintenance dose, right? That is the best tocolytic, that is nifedipine. Best tocolytic in heart disease patients, that is atosiban, and best tocolytic in a diabetic patient is again nifedipine. In diabetic patients, beta agonists are contraindicated because their side effects is hyperglycemia, right? Now, let's talk about a lung maturity test. All of you know that the most common lung maturity test is the lecithin upon sphingomyelin ratio, and if lecithin upon sphingomyelin ratio is more than 2, that indicates that the lungs of the baby are mature. Number 2, or the best test for lung maturity, is phosphatidylglycerol. If phosphatidylglycerol is present in amniotic fluid, we know that the lungs of the baby are mature. The third test for lung maturity is the shake test. Now, because surfactant is a soapy material, if you are taking amniotic fluid and you are shaking it and you get bubbles, right, that indicates that yes, lungs of the baby are mature. Next test is the Nile blue sulfate test, very, very important test. This is an indirect test. Till now, whatever I was telling you, they were direct tests for knowing lung maturity. Nile blue sulfate test is an indirect test where you are going to take amniotic fluid, and we all know that amniotic fluid has got fetal skin cells. You are going to centrifuge the amniotic fluid so that you get the fetal skin cells, and these fetal skin cells, you are going to stain them with Nile blue sulfate dye. Now, if fetal skin cells, they have got fat present, they appear orange in color. So, if you are getting more than 50% orange colored cells on Nile blue sulfate test, that indicates that the lungs of the baby are mature. So, two misconceptions about Nile blue sulfate test which make the question wrong is that Nile blue sulfate test is not telling you about skin maturity, it is telling you about lung maturity, right? And number 2, in Nile blue sulfate test, the cells will not appear blue in color, the cells are going to appear orange in color. Apart from this, 2 other tests, one is the TDX FLM2 test. TDX FLM2 test, it detects the ratio of surfactant and the albumin, right? Now, TDX FLX2 test, again, that's, a recent test, and we don't do that just now much. And the next test is the lamellar body test, right? So, these are all the tests which are there for the lung maturity. Now, so let's go back to our questions. Question number 5 was, a 32 weeks pregnant female presented with labor pains and minimum cervical discharge. On analysis of the cervicovaginal discharge showed fibronectin. Now, if patient is having pains, right, and fibronectin is present, that indicates that yes, it is preterm labor. Remember that fibronectin can also be present whenever there is premature rupture of membrane. So, it can be present in preterm labor, it can be present in premature rupture of membranes. All of the following indicate fetal lung maturity except. So option A, lecithin upon sphingomyelin ratio more than 2, yes. Positive shake test, yes. Increased phosphatidylglycerol, yes. Blue cells in Nile blue sulfate test, no. It's the orange colored cells in Nile blue sulfate test, right? Let's go further. A 28 weeks pregnant female presents with fetal distress on examination, and when a Doppler study was done, you got this image. What should be the next step in management, right? Now, first of all, in this Doppler, what I am seeing is that yes, blood flow is present during the systole. So, blood flow is present during systole, but there is no blood flow in diastole, right? So, if you are getting an image like this, where there is blood flow only during systole and there is absent blood flow during diastole, that is absent end diastolic flow. If on Doppler, you are getting an image like this, where during systole blood is flowing in one direction and during diastole it's the reverse direction, right? That means it is reversed end diastolic flow, which is seen here in the next Doppler. So here blood flow is present in systole in one direction and it's opposite in the diastole, like this. So this is a reversed diastolic flow. Now, I have already explained to you in class that blood flows from the heart to all the arteries at the time of systole as well as at the time of diastole. But during systole, it is the active contractions of the heart which leads to blood going into the arteries, right? But during diastole, this process is a very, very passive process, right? So, if suppose the patient's blood pressure is high, if her resistance, if suppose patient's blood pressure is very high, or in other words, the resistance which is offered by the vessels is very high. This resistance is not going to affect her blood flow during systole, but it is going to affect her blood flow during diastole, right? What happens when the blood pressure increases? Now, when the blood pressure increases, in other words, the peripheral resistance increases. So, what is going to happen is that the blood flow in the vessels is going to absolutely be zero, right? And that is called as absent end diastolic flow. And if resistance becomes higher, then instead of blood flowing into the arteries during diastole, the blood starts flowing out of the arteries during the diastole. And that is called as reversed diastolic flow, right? Now, in order to understand at what time am I going to terminate pregnancy in them, let's talk a little bit quickly about PIH and the doses of the drugs which you need to know in PIH. So, again, you are going to make that table: the problem, the drug, the dosage, the update, and the management. So, in PIH, for the drug of choice for PIH is the Labitolol. Or if they ask you the drug of choice for Preeclampsia, that is Labitolol. If they ask you the drug of choice for chronic hypertension in pregnancy, again that's Labitolol. The second drug of choice is methyl-dopa. And if they ask you what is the drug of choice for hypertensive crisis, you are going to say again it is Labitolol, but now it is given in IV forms. Now, the IV dosage of Labitolol, which is given in hypertensive crisis, that is something which you have to remember. The IV dose of Labitolol is, it's immediately start when a patient comes to you with very high BP, you are going to give 20 mg IV, and then if the BP doesn't settle down, within 10 minutes, you are going to give again 40 mg. And if the BP doesn't settle down, then again in 10 minutes, you are going to repeat 80 mg. And if again it doesn't settle down, then again 80 mg. So 20, 40, 80, 80. That makes it a total dose of 220 mg. Now, if the BP isn't settled by IV Labitolol, then I'm going to give her IV hydrolysine. If it is not settled by that also, then I'm going to give her sustained release tablet of nifedipine. We do not use sublingual tablets of nifedipine. And the last resort, if there is refractory hypertension, then it is sodium nitroprusside. One very important point which you have to remember about IV Labitolol is that you do not give it in asthmatic patients. It is contraindicated in asthma. Right? Now, the update which you have to remember here is that the safest antihypertensive, if they ask you, you are going to say that the safest antihypertensive is methyl-dopa. Now, you're going to say that, ma'am, you have told me that the best drug for hypertension, for PIH and for chronic hypertension is Labitolol, but then safest antihypertensive, I'm saying methyl-dopa. That is because methyl-dopa, it has a little slow action. right? And when you give methyl dopa at higher dosages, it has got sedative action. That is why methyl dopa is not the drug of choice, but yes, it is the safest antihypertensive in pregnancy. Now, what is the indication for starting antihypertensives? Indication for starting antihypertensive is whenever there is severe BP, that there is severe preeclampsia, or very high BP, that is more than 160 by 110. Now, this is what we have already done. One thing more which you have to remember is that the latest recommendations say that if BP is more than equal to 150 by 100 and it is persistent, then also you can start antihypertensives. So, you have to start antihypertensive when it is 160 by 110. But if it is 150 by 100 and it is a persistently raised BP, then also you have to start an antihypertensives. Now, the antihypertensives which are contraindicated in pregnancy, all of you know that it is ACE inhibitors, then it is losartan, that is the angiotensin receptor blocker. Then we have the beta blockers, the diuretics and diazoxide. These are the antihypertensives which are contraindicated in pregnancy. The termination of pregnancy, if it is mild preeclampsia, and mild preeclampsia means that BP will be less than 160 by 110, but it will be more than 140 by 90, right? Now, in this case, and in case of mild preeclampsia, you do not get the signs and symptoms of end organ damage. These are only two ways in which you can differentiate mild preeclampsia from severe preeclampsia. In severe preeclampsia, BP will be more than 160 by 110 and signs symptoms of the end organ damage will be present. Proteinuria is not a criteria to differentiate between mild preeclampsia and severe preeclampsia, that all of you know. Now, in case of mild preeclampsia, the time at which you terminate pregnancy, that is 37 weeks, and in case of severe preeclampsia, the time at which you terminate pregnancy is 34 weeks. So, in case of hypertension in pregnancy, the PIH in pregnancy, what are the indications for terminating pregnancy at 34 weeks? Okay, indications are if patient has got severe preeclampsia, and number two, if you are getting absent end diastolic flow. Right. So, if you are getting an absent end diastolic flow on the umbilical artery Doppler, you are going to terminate pregnancy at 34 weeks. Now, what if the patient is less than 34 weeks and you are getting absent end diastolic flow? If patient is less than 34 weeks, you are going to give her corticosteroids and you are going to monitor the fetus, right, by doing an NST and by doing biophysical profile. Why am I going to monitor? Because a finding of absent end diastolic flow within a week, it can change to reversed diastolic flow, right? So, you will have to monitor this pregnancy, and while monitoring, you will try that you take it up till 34 weeks, right? But if it is more than 34 weeks, you have to terminate her pregnancy. So, look at the question which was given to you. The question said a 28 weeks pregnant female presents with fetal distress and fetal distress on examination, and a Doppler study is given below. What should be the next management? The options, so this is absent end diastolic flow. Options are option A, immediate termination of pregnancy. See, patient is 28 weeks. At 28 weeks in absent end diastolic flow, I am not going to terminate pregnancy. Give her steroid and do cesarean section? No. Give her steroid and do vaginal delivery? No. Give her steroid, do a Doppler and biophysical profile and then plan delivery? Yes, that is what I am going to do if pregnancy is less than 34 weeks, right? Now, continue your table. What are the conditions in PIH when you are going to immediately terminate the pregnancy? You are going to immediately terminate pregnancy irrespective of gestational age if it is eclampsia, if the patient develops eclampsia, or if the patient develops HELP syndrome. Then if in PIH, if there is fetal distress or because of high BP there is abruptio placenta, or if her BP is uncontrolled, right, and her serum creatinine levels are continuously rising, then you are going to go for immediate termination of pregnancy. And if there is reversed diastolic flow, in reverse diastolic flow also you go for immediate termination of pregnancy. There are recommendations which are saying that in reverse diastolic flow also you have to wait up till 32 weeks, but those recommendations are just recommendations just now. For your question purpose, you are going to say that if you get a Doppler of reverse diastolic flow, irrespective of the gestational age, you have to terminate pregnancy, right? Now, in case of eclampsia, one very important question is, what is the first step what you do in the management of eclampsia? All of you know that the first step in the management of eclampsia is airway management, right? And after that, you have to give magnesium sulfate in order to prevent convulsions also and treat convulsions also. It is the drug of choice, right? Now, so let's talk about the treatment of convulsions in a PIH patient. That is, let's talk about magnesium sulfate, right? A question which recently came in the AIIMS exam also. Now, magnesium sulfate, very, very important, the dosage of magnesium sulfate. Now, the dosage of magnesium sulfate, we have the Pritchard regime and we have the Sebai regime, right? In Pritchard regime, the loading dose of magnesium sulfate, please note it down, that's very important, and we've done it already in classes also, but I'm revising it with you. It is 4 grams you have to give IV. Now, when you give 4 gram IV, what you have to understand is this is 20% 4 gram IV magnesium sulfate, right? And along with this, you are going to give 10 grams intramuscularly. Now, this 10 gram intramuscularly is 50% magnesium sulfate. So, 4 grams IV, which is 20%, and 10 grams IM, which is 50%, 5 grams in each buttock, right? This is the loading dose in Pritchard regime. And then this has to be followed every 4 hourly by a maintenance dose. Maintenance dose is 5 grams intramuscularly, which is 50%, right? 5 grams of 50% magnesium sulfate. Now, when I say that you have to give 20% of magnesium sulfate when you are giving IV dose, what you have to understand is that magnesium sulfate, which is available, is 50% solution. Now, what do you understand by this 50% solution? By 50% solution, I mean that if I have a 10 ml vial of magnesium sulfate, this 10 ml vial of magnesium sulfate will have 5 grams of magnesium sulfate. In other words, per ml, the amount of magnesium sulfate which is present is 0.5 grams, right? So this is how it is available. Always magnesium sulfate is available as a 50% solution, right? So when I have to give intramuscularly, I don't mind because I have to give a 50% solution. I have to give 5 grams, right? So if I have to give 5 grams in each buttock, I will give 10 ml in each buttock, right? Now comes when I have to give IV dose. In IV dose, I have to make it 20%. So what I'm going to do is I have to give her 4 grams. Now, when you have to give 4 grams, you will take a 20 ml syringe, and in that 20 ml syringe, you are going to add 8 ml of magnesium sulfate. Why you are adding 8 ml? Because per ml has 0.5 grams. In other words, for 4 grams, you need 8 ml, right? So, you will take 8 ml of magnesium sulfate and then you will add 12 ml of normal saline, right? So, that makes it that in a 20 ml solution, there is 4 milligrams of magnesium sulfate. In other words, this magnesium sulfate will now be 20% magnesium sulfate. Is that clear to all of you? Right? The next very important question about magnesium sulfate is the therapeutic range of magnesium sulfate. The therapeutic range of magnesium sulfate is 4 to 7 milliequivalents per liter. Now, if they ask you millimoles per liter, you simply have to half it, right? Whatever I told you 4 to 7. So now that is milliequivalent. Now, in millimoles, it will be 2 to 3.5, right? And if they ask you in milligrams, it is 4.8 to 8.4 milligrams per deciliter. So, remember all the 3 therapeutic ranges. Most commonly, they will ask you milliequivalents per liter, and it is 4 to 7 milliequivalents per liter. For millimoles per liter, you have to divide it by 2. So, that is 2 to 3.5 millimoles per liter. And for milligrams per deciliter, it is 4.8 to 8.4 milligrams per deciliter. Now, because magnesium sulfate has such a narrow therapeutic range, I told you that you have to check the following parameters before you give the next dose of magnesium sulfate when you are giving the maintenance dose. And what are the parameters which you are going to check? The parameters which you are going to check is, number 1, you are going to check the deep tendon reflex or the patellar reflex or the knee jerk, right? Number 2, you are going to check her respiratory rate. If her respiratory rate is more than equal to 12, then only you are going to give the dose of magnesium sulfate. If knee jerk was present, then only you will give the maintenance dose. Third thing what you have to check is urine output. Urine output, it should be more than 30 ml per hour. And number 4, you are going to check the oxygen saturation, which is the best thing, right? That's the best out of all these. and the oxygen saturation, it should be more than 96%. Only if all these 4 things are present and normal, then only I will give the maintenance dose. Otherwise, we do not give the maintenance dose, right? That is how you have to give magnesium sulfate. So look at this question here. 35 weeks multigravida with PIH with epigastric pain, headache and visual symptoms and proteinuria. What is the next step? Now this patient is having this patient is having PIH and she's having epigastric pain, headache and visual symptoms, which means she's a case of impending eclampsia. And whenever you have a PIH patient, a severe preeclampsia patient with impending eclampsia, the first thing which you have to give is a drug which prevents convulsions. And again, the drug of choice is magnesium sulfate. So you're going to give magnesium sulfate IV. Right? Next. So question number 9, 10, 11, 12, which are there on your screen, they are related to PPH, and so that means now next topic which we are going to do is PPH, and then we'll come back to these questions, right? So now PPH. Now in PPH, we know the first thing what you have to remember is that in order to prevent PPH, you have to do active management of the 3rd stage of labor. That is the best method to prevent PPH. And in active management of 3rd stage of labor, the steps are that first step is you have to give injection uterotonic after the delivery of the anterior shoulder of the baby. That's one thing. Number 2, you have to go for a delayed cord clamping. Number 3, you have to deliver the placenta by controlled contraction. And number 4, you have to go for intermittent uterine tone assessment. Earlier, this 4th step was uterine massage, but nowadays this is not a step of the active management of 3rd stage of labor. Right? But just in case you have a question which says all of the following are steps of active management of 3rd stage of labor except, and in that except, you have 2 options. One of the options is early cord clamping and one of the options is uterine massage. In that case, please go for early cord clamping as the answer, because early cord clamping is not going to affect whether PPH is going to happen or not. Right? So in those 2 cases, the answer would be early cord clamping. But otherwise, yes, uterine massage is not these days included as a method of prevention of postpartum hemorrhage. The other exception is if in your questions you are getting both oxytocin and methyl ergometrin. What you have to remember is methyl ergometrin, it has always to be given intramuscularly. If they are saying in your questions that methyl ergometrin is given IV, right? IV methyl ergometrin, it leads to hypertension. So in that case, that becomes a incorrect option. So do not mug up the answer to this question. Depending upon the options which are given to you, you are going to answer that question, right? Now, in case of uterotonics, the WHO recommends the uterotonic oxytocin, and the dose of oxytocin for active management of 3rd stage of labor, that is 10 international units. Oxytocin, it should always be given intramuscularly or by IV infusion. It should never be given IV bolus. That is what you all know, and because it leads to hypotension and it leads to cardiac arrest. Right? If the oxytocin is not available, then WHO recommends that you can go for methyl ergometrin. The dose of methyl ergometrin is 0.2 mg intramuscularly. You should not give methyl ergometrin IV because that leads to high BP. Right? Then you can give a fixed dose combination of oxytocin and methyl ergometrin, that is synthometrin, which is 5 units of oxytocin and 0.5 mg methyl ergometrin. Then you can give misoprost for preventing PPH. The dose of misoprost as recommended by WHO is 600 micrograms, which you have to give sublingually. You do not give misoprost per rectally, right? So WHO is not recommending it per rectally. The next drug which you can give is misoprost. Misoprost is PGE1, and the dose which is recommended by WHO for preventing PPH, all of you know, that is 600 micrograms oral dose, and that's very, very important dose to remember. A very, very good prostaglandin to prevent as well as to treat PPH is carboprost. The dose of carboprost, that is PGF2 alpha, very important. It is 250 micrograms intramuscularly. Carboprost is one of those drugs. Suppose if oxytocin fails, if methyl ergometrin fails, then the next drug which you should look up to is carboprost, right? And you can also give carbetocin. Now, carbetocin is synthetic oxytocin, and the dose of carbetocin is 100 micrograms slow IV. Do not confuse between carbetocin and carboprost. Carbetocin, the dose is 100 micrograms, which you have to give slow IV, whereas carboprost is 250 micrograms intramuscularly. Please remember that. Right? Another drug which you have to remember is dinoproston, which is PGE2. Now, PGE2 is the dinoproston is not recommended by WHO, but yes, off-label, as an off-label drug, it is being used to treat PPH, but it is not a drug which is recommended by WHO. So, if you have a question where they say all of the following are used in management or in prevention of PPH except, right? In that except, if you get dinoproston, mark that as the answer, right? Because dinoproston is not recommended by WHO, right? The dose of dinoproston which is being used is 20 milligrams suppository per rectally, right? Now, we were talking about the steps of active management of third stage of labor, and I told you a very important step is that you have to go for delayed cord clamping. Now, there are certain conditions in which you do early cord clampings, and those indications are very, very important for you to remember. Early cord clamping, it is done in case the baby is having birth asphyxia or the baby has to be resuscitated, right? So, in that case, I'm going to hand over the baby immediately to the pediatrician, number one. Number two, if baby is a known case of heart disease, in that case, I'm going to go for early cord clamping. Number three, in Rh negative pregnancy. And number four, which I'm going to tell you is HIV positive females. Now, why I have included HIV positive female in early cord clamping is because WHO's guidelines, they say that in case of HIV positive females, you can go for delayed cord clamping. But the NACO guidelines, which have come very recently, they say that in case of HIV positive females in India, we go for early cord clamping. So we are going to follow the NACO guidelines, and from now onwards, we are going to put HIV positive females in early cord clamping category, right? Okay. The other things which you have to remember are the side effects of prostaglandins. In carboprost, what you have to remember that the side effect is diarrhea, and carboprost, it should not be given to a female who has bronchial asthma. And the side effect of mesoprost, that is hyperthermia, patient can have hyperthermia and shivering with mesoprost, and mesoprost is contraindicated in a previously scarred uterus. So in a patient of previous cesarean section, we do not use mesoprost, right? Next. So now this was about the active management of third stage of labor. Let's talk about the treatment of PPH, that was prevention of PPH. In treatment of PPH, one thing what you have to remember is that I told you the definitions for PPH were if the blood loss is more than 500 milliliters in a vaginal delivery, or if it is more than 1000 ml in a cesarean section, or more than 1000 ml in twin deliveries, or more than 1500 in a cesarean hysterectomy. Now, as per the recent ACOG guidelines, they say that if blood loss is more than equal to 1000 ml, irrespective of the type of delivery which has happened, then you call it as PPH. Right? Now, again, the drugs for treating PPH are same like the drugs which we're using for preventing PPH, except for one drug. In treating PPH, you can use injection tranexamic acid also, which is not used for preventing PPH. The dosages of the drugs, they do vary. Number one, oxytocin. For treatment of PPH, you are going to use 20 to 40 international units of oxytocin. Number two, methylergometrin. Again, methergin or methylergometrin, you are going to use it 0.2 mgs intramuscularly. And you can repeat methergin every 2 to 4 hours, and the maximum dose which you are going to give is up till 5 doses, right? Then mesoprost, as per WHO recommendations, the drug for the dose of mesoprost for treating PPH, it is 800 micrograms sublingual, right? Now, if you are using mesoprost per rectally, which is not recommended by WHO, but yes, we use mesoprost per rectally, then per rectal dose of mesoprost is 1000 micrograms. Right? Then PGF2 alpha carboprost, it is 250 micrograms intramuscularly, which you can repeat after every 15 to 90 minutes, and maximum you can take it up till 8 doses, right? Then you can give injection tranexamic acid. As I told you, the dose of injection tranexa is 1 gram. You have to give slow IV for 20 minutes, right? So these are the drugs which are used for treating PPH. Remember, you are going to give oxytocin initially. If oxytocin is not benefiting, then simultaneously, when you see that the patient has been detected with the PPH, simultaneously you start doing a uterine massage and you give her tranexamic acid, and still the bleeding is not controlled, then you give her methylergometrin, and then last drug, or the best drug which you should go for, is the carboprost. Right? Then just one last thing which I want to revise with you quickly is what are the contraindications for giving methergin or methylergometrin. The contraindications for giving methergin or methylergometrin are TOPER, where T stands for after the delivery of first twin, O stands for any organic heart disease, P stands for severe preeclampsia, E stands for eclampsia, and R stands for Rh negative pregnancy, TOPER. I hope you remember that. Right? So this is what you had to remember about PPH. Another thing, if medical management, it fails within half an hour. You're going to try medical management only for 30 minutes. If in 30 minutes the medical management fails, then you are going to go for the mechanical methods, and in mechanical methods you are going to use the balloon tamponade, in which I am going to use a Buckley balloon catheter. In Buckley balloon catheter, I am going to fill it with normal saline, and the maximum capacity of a Buckley balloon catheter is 500 cc. Now, WHO says that there are certain methods which can be used as temporary methods to relieve the blood flow, to relieve the blood loss, and that is, you can go for external aorta compression, or you can go for bimanual compression, or you can go for anti-shock garments, the military anti-shock garments. Uterine packing is not recommended by WHO as a method to treat PPH. Yes, uterine massage, it is recommended by WHO as a method to treat PPH, but not uterine packing, right? Now, if the mechanical methods also fail, then you will go to surgical methods, in which we have done that you are going to apply the B-link sutures, or you are going to ligate the arteries which supply the uterus. In other words, you're going to ligate the uterine artery, the ovarian artery, and if that also doesn't suffices, then you are going to ligate the anterior division of the internal iliac artery. Anterior division of the internal iliac artery, it should be ligated 5 centimeters below its origin from the common iliac artery, right? Then let's talk about the final management. The final management, if nothing is working, is that you have to take up the patient for hysterectomy. And which hysterectomy do you do in a PPH patient? That's a subtotal hysterectomy, right? Okay, so let's quickly do the questions which are there on PPH. So recently all these questions have been asked. Drugs preventing PPH, all except, and the options were option A misoprost, option B dinoprost, option C PGF2 alpha, and option D oxytocin, right? So you tell me misoprost, yes, you use it. Dinoprost, I told you it's an off-label drug. PGF2 alpha, you use it. And yes, oxytocin, that's the best, that is the first method to use. Now for this, I want you to see this text over here. In order to substantiate my point, I have this text from Williams, which is saying that dinoproston PGE2 may be used off-label, right? And the dose is 20 milligrams suppository per rectum, right? So it may be used, but yes, it's not one of the best drugs to use. So in the questions, you had drug preventing PPH, misoprost, dinoprost, PGF2 alpha, oxytocin. I'm going to mark the answer as dinoprost, right? Then question number 10, drug of choice of PPH resistant to oxytocin and ergometrin. I told you whenever it is resistant to oxytocin and ergometrin, you have to go for carboprost. The dose of misoprost in emergent management of PPH, right? For the management of PPH, the dose is 800 micrograms, which you have to give sublingually. Carbitocin dose for PPH, the carbitocin dose for PPH, it is 100 micrograms IV. Right? Now, I was telling you that NACO recently has said that you have to do early cord clamping in a patient of HIV. So, let's talk a little bit about the recent guidelines of NACO for management of HIV patients. Now, NACO says, number one thing, that all pregnant females, irrespective of their CD4 counts, you have to start a triple regime ART in them, irrespective of the gestational age at which they are coming to you. So, in any trimester, any gestational age, and at any CD4 count, you have to start a triple regime ART with them, right, irrespective of the CD4 counts. Now, the triple regime ART which you give in a pregnant female, which is recommended by NACO, it consists of tenofovir, number 1, number 2, lamivudine, and number 3, efavirenz, right? Now, if a patient is coming to you at the time of labor and her status is not known, her HIV status is not known, you are going to send her test for HIV immediately, and if her HIV status comes out to be positive, in that case, immediately you are going to start the triple regime ART. Right now, as far as the newborn babies are concerned, to all the newborn babies who are born with HIV positive, who are born to HIV positive females, you have to give them nevirapine. The duration of nevirapine, it differs. Now, to all the newborn infants who are born to a pregnant female with HIV, you have to give them nevirapine. The duration of nevirapine is going to differ. In patients who were taking ART, to their children, to their infants, you are going to give nevirapine for 6 weeks. But if the patient was not on ART, or if she was on ART for less than 4 weeks before delivery, then the duration of ART, the nevirapine which you have to give to the newborn baby, is 12 weeks. right? So this is how you give nevirapine therapy. I'm repeating that. In infants who are born to mothers who were taking ART throughout pregnancy, you have to give them nevirapine only for 6 weeks. But if an infant is born to a mother who was not taking ART or who was taking ART just now, only very recently she had started, and it is less than 4 weeks, then you are going to give them this nevirapine for 12 weeks, right? So next, what are the interventions which are suggested by NACO for during labor and delivery? Number 1, NACO says you have to minimize the vaginal examinations. Number 2, you have to avoid prolonged labor. You should consider oxytocin to shorten the labor time. You should avoid artificial rupture of membranes. And the one line which I have highlighted is that you have to go for early cord clamping. You should use non-invasive fetal monitoring methods, like you should go for non-invasive procedures. You should use non-invasive fetal monitoring methods. You should avoid the invasive procedures. You should avoid routine episiotomy, and you should avoid using forceps or vacuum in such children, right? As far as the mode of delivery is concerned, NACO says that the mode of delivery for a patient, HIV positive female who is on ART, it is vaginal delivery, right? Cesarean you are going to do only for obstetrical indications. The mode of delivery has to be vaginal delivery, right? According to NACO, in HIV positive females, breastfeeding is not contraindicated. What you have to tell her is that she has to go for exclusive breastfeeding for 6 months. So these are the NACO guidelines for HIV females during pregnancy. So now read this question. All of the following are done in AMTSL except IV ergometrin after the delivery of anterior shoulder. You never give IV ergometrin because IV ergometrin will lead to hypertension. Oxytocin, yes. Uterine massage plus minus. Delivery of the placenta by controlled traction, yes. So the answer here is option A. Clear? Now, I was talking about that NACO recently has given its guidelines that early cord clamping is done in a patient of HIV. So how do you manage an HIV patient during pregnancy? Now, according to the recent NACO guidelines, whenever a patient comes to you, whenever a pregnant female comes to you with HIV, you have to give her the 3-drug ART regime. That's number 1 thing what you have to do. This ART regime, it should be given, it can be given at any time during pregnancy and irrespective of the CD4 count. So, irrespective of the CD4 count, you have to give a 3-drug ART which can be started at any time during pregnancy. Now, what are the 3 drugs which you are going to give? Number 1, you are going to give a tenofovir. Number 2, you will give lamivudine. And number 3, you are going to give efavirenz. This is the 3 drugs which you have to give, right? Now suppose patient doesn't come to you during pregnancy, she's coming to you at the time of labor. Now if patient is coming at the time of labor and her HIV status is not known, you are going to get an immediately HIV test done, right? And then you are going to start ART, the 3-drug ART, right? Now any newborn baby, any newborn infant who is born to an HIV mother, right? To that infant, you have to give nevirapine, and the dose of nevirapine which you are going to give to the baby will be the same, but the duration is going to vary, right? Nevirapine, it should be given for 6 weeks if the patient was on ART, if the baby's mother was on ART, then the duration has to be 6 weeks. If mother was not on ART, then the duration has to be 12 weeks. Or if the mother was on ART, but she was on ART for less than 4 weeks before delivery happened, right? In that case, you have to give nevirapine to the newborn baby for 12 weeks. Otherwise, you have to give it for 6 weeks, right? Now, during labor, the mode of delivery which is recommended by NARCO is vaginal delivery in an HIV patient irrespective of the CD4 counts. Then during vaginal delivery, there are certain precautions which you have to take. You do not have to go for any invasive procedures, like you do not have to try to avoid artificial rupture of membranes, that is a contraindication. Then episiotomy should be avoided in such patients. Forceps and vacuum should be avoided in such patients. You should go for minimum per vaginal examinations in HIV patients, and you should not go for any invasive procedures, right? So all these things should be avoided in an HIV patient. Cord clamping, as far as cord clamping is concerned, it has to be an early cord clamping in HIV patient, HIV positive females. So these are the recent NARCO guidelines for managing HIV in pregnancy, right? Now, let's talk about the dose of folic acid in pregnancy. Now, for talking about the dose of folic acid in pregnancy, I want you to remember 3 doses, right? Number 1, in what conditions are you going to give 400 micrograms per day? 400 micrograms of folic acid is given to prevent neural tube defects in all pregnant females, right? So to all pregnant females, I'm going to give her 400 micrograms of folic acid. And what time am I going to start it? I'm going to start it 1 month before conception, and I'm going to continue it for 3 months after conception, right? Number 2, I am going to give 400 micrograms of folic acid to all pregnant females who are on anti-epileptic drugs which do not lead to neural tube defects. For example, lamotrigine, right? So if a patient is on lamotrigine, I'm going to give her 400 micrograms per day. Number 3, I am going to give 400 micrograms to all pregnant females with diabetes. Earlier, the dose which was given to diabetes was 4 mg, but then later ACOG said, and this is a very strong recommendation by ACOG which is being followed, is that in all diabetic females, now you have to give the dose as 400 micrograms per day. So please make that change here, note it down, and note it down in your notes also, right? Then, under what circumstances are you going to give 1 milligrams per day of folic acid? 1 milligram per day of folic acid should be given to all pregnant females in whom there is a neural tube defect in the 2nd degree or the 3rd degree relative, right? So in that case, the dose of folic acid becomes 1 milligram per day, right? Number 2, if the pregnant female has megaloblastic anemia, in that case, the dose becomes 1 milligrams per day. Number 3, if a pregnant female is on any drug which decreases the dose of folic acid, right? For example, trimethoprim and sulfasalazine, they decrease the dose of folic acid. So in that case, I am going to give her 1 milligrams per day of folic acid, right? Now, under what conditions do you give 4 milligrams per day? You are going to give 4 milligrams to all pregnant females who themselves have a previous history of delivering a neural tube defect baby. So if the female herself has a history of delivering previous neural tube defect baby, the dose becomes 4 milligrams per day. If there is history of a neural tube defect in a 2nd degree or a 3rd degree relative, then I told you the dose is 1 milligrams per day, right? Number 2, you are 4 milligrams per day is given if the female has sickle cell anemia, if a pregnant female has sickle cell anemia. Number 3, you are going to give 4 milligrams per day if the patient is on anti-epileptic drugs like valproic acid or carbamazepine, which lead to neural tube defects. As far as sickle cell anemia is concerned, in the options 5 milligrams per day, if it is given, then that's a better answer than 4 milligrams per day also, right? In sickle cell anemia, you give 5 milligrams per day. If that is given, that's always a better option, right? So this is the dose of folic acid during pregnancy. Then let's talk about the dose of iron during pregnancy. Now, iron supplementation is mandatory for all pregnant females, and we have the Anemia Mukt Bharat program. According to the Anemia Mukt Bharat program, you have to give 60 milligrams of elemental iron and 500 micrograms of folic acid to all pregnant females starting from 4th month of pregnancy. This ideally should be continued throughout pregnancy, but at least you should give it for 180 days during pregnancy and for 180 days after delivery. Why you give it for 180 days after delivery? That is to replenish the iron stores. What is the first marker to decrease whenever there is iron deficiency anemia? That is serum ferritin levels, right? Now, whether you give oral iron or whether you give parenteral iron, the rate of increase of hemoglobin is the same, and this is seen after 3 weeks of giving oral or parenteral iron, and the rate is 0.5 to 1 gram per week. So the rate of increase of hemoglobin after giving oral iron and parenteral iron, it's the same, and all of us know it is 0.7 to 1 grams per week, right? But the rate of increase will be seen after 3 weeks. Also, what is the definition for anemia in pregnancy? The definition for anemia in pregnancy is if hemoglobin becomes less than 11 grams percent. Severe anemia is when hemoglobin is less than 7 grams percent, and very severe anemia is when hemoglobin is less than 4 gram percent, right? Now, another thing what you have to know is what are the indications for blood transfusion during pregnancy. The indications for blood transfusion are if at less than 34 weeks of pregnancy, patient's hemoglobin is less than 5, if and there are no signs of heart failure, right? Number 2, if at more than equal to 34 weeks, her hemoglobin levels are less than 7 and still there are no signs of heart failure. Number 3, at any gestational age, if there are signs of heart failure, you have to give a blood transfusion. And number 4, if patient is coming to you during labor and her hemoglobin is less than 7, right? And number 5, if patient is having acute bleeding, and because of that acute episode of bleeding, her hemoglobin has become less than 6. So these are the indications for blood transfusion during pregnancy. Less than 34 weeks, hemoglobin less than 5. More than 34 weeks, hemoglobin less than 7. At the time of labor, hemoglobin less than 7. And due to acute bleeding, hemoglobin less than 6. So these are the indications for blood transfusion, right? Next. What are the possible causes of choriocarcinoma after hydatiform mole? All except, right? Option A, rising HCG levels. Option B, more theca lutein cysts. Option C, increased uterine size. And option D, suburethral nodule. Now, so to understand this question and to answer this question, let us discuss it quickly about molar pregnancy. Now, in molar pregnancy, you know that we have a complete mole and we have a partial mole, right? In complete mole, the karyotype of a complete mole is 46XX. That means they are diploid and most of the times they are monospermic. And why I'm saying most of the times they are monospermic is because when the karyotype is 46XX, which is in 90% cases, they are monospermic. But if the karyotype is 46XY, then they are dispermic, right? Now, in case of molar pregnancy, the complete mole, the entire genetic material is obtained from the father. It is a sperm which will fertilize an empty ova, so the entire genetic material belongs to the father. In case of a complete mole, the HCG levels are very, very high and they are more than 10 to the power of 5 international units. Then, in case of complete mole, the period of gestation, the height of the uterus will be more than the period of gestation and you will get big theca lutein cysts. These theca lutein cysts will be more than 6 centimeters in size and they will be bilateral, right? And when you do an ultrasound in case of a complete mole, you get a snowstorm appearance, right? So this is something which we know about a complete mole. Let's talk about partial mole. Partial mole, it is triploid and its karyotype is 69XXY. Now, in case of a partial mole, mostly they are dispermic, right? And it is an ova which is fertilized by 2 sperms. The extra genetic material which they get, that belongs to the father. In a complete mole, the entire genetic material belongs to the father. Now, in case of partial mole, all the manifestations of molar pregnancy will be less. So, the HCG will be increased, but it will be less than 10 to the power of 5 international units. As far as the height of the uterus is concerned, height of the uterus will either be equal to the period of gestation or it will be less than the period of gestation, and you will not get theca lutein cysts in case of a partial mole, right? Now, what is the most common gestational trophoblastic neoplasia which is seen after a H mole? The most common gestational trophoblastic neoplasia seen after H mole is invasive mole. But if they ask you which choriocarcinoma is most commonly seen after, then choriocarcinoma is most commonly seen after a molar pregnancy. So these are 2 different questions which you have to remember. What are the chances of a complete mole changing into gestational trophoblastic neoplasia? The chances are 15%. And what are the chances of complete mole changing specifically into choriocarcinoma? The chances are 4%. Now, as I am telling you that the chances of a complete mole changing into choriocarcinoma are very, very high. So let's see. So what are the chances of a complete mole changing into gestational trophoblastic neoplasia? The chances of complete mole changing into gestational trophoblastic neoplasia is 15%, and the chances of a complete mole changing into a choriocarcinoma specifically is 4%. Right? And how do you manage a molar pregnancy? The management of molar pregnancy is suction evacuation, which should be done at all the irrespective of the size of the uterus. But if the female's age is more than equal to 40 years, that means she's completed her family. In that case, you're going to do hysterectomy. Now, whether you do hysterectomy or whether you do suction evacuation, you have to follow up a molar pregnancy by doing HCG levels. Just because you have done hysterectomy, that doesn't mean you are not going to do the follow-up. right? Then what is the investigation of choice in a molar pregnancy? You know that investigation of choice in a molar pregnancy is ultrasound, and on ultrasound you get a snowstorm appearance. So this is how a snowstorm appearance looks like, right? So this is the snowstorm appearance which you get on ultrasound, right? Then the next question which they can ask you, what is the gold standard for a molar pregnancy? The gold standard for a molar pregnancy is histopathological examination, and in case of a molar pregnancy, once you've evacuated the H mole, you have to follow up the patient with beta HCG levels for 6 months, and during this 6 months you have to tell the patient that she should not take any she should not become pregnant, and you have to advise her contraception in the form of oral contraceptive pills, right? Now, as I told you, the chances of a complete mole changing into a choriocarcinoma, they are very, very high. So what are the risk factors that a molar pregnancy can change into choriocarcinoma? The risk factors are, number 1, if age of the patient is more than 40 years. Number 2, if her HCG levels are more than 10 to the power of 5. Number 3, if the size of her uterus is very, very big and it's more than the period of gestation. And number 4, if she has bilateral thecal lutein cysts which are more than 6 centimeters in size. So these are the risk factors that yes, this female can have, her molar pregnancy later can get converted into choriocarcinoma, and in all such females you will have to give them a prophylactic chemotherapy. The drug of choice for prophylactic chemotherapy is methotrexate, right? Now, how does the patient of choriocarcinoma present to you? The patient of choriocarcinoma can present to you that after molar evacuation she's been having persistent bleeding, or her uterus remains enlarged after evacuation of the molar pregnancy. That means she can be a case of subinvolution. Number 3, she can come to you as a case of persisting thecal lutein cysts. See, normally in a case of molar pregnancy, if they ask you how do you manage a thecal lutein cyst, you will say that we do not do anything to manage thecal lutein cyst. Thecal lutein cysts, they automatically resolve after suction evacuation within 2 to 4 months. That is one thing. Number 2, they ask you that at what time does the HCG levels, they come back to normal in a partial mole and in a complete mole. In case of partial mole, the HCG levels come back to normal at the end of 7 weeks, whereas by 9 weeks it comes in a complete mole. Now, if the thecal lutein cysts are persisting, in other words, her HCG levels are persisting or they are increasing, this indicates that yes, this patient has developed choriocarcinoma. Apart from that, if she has signs of metastasis, then that indicates that she is having choriocarcinoma. Now, in case of choriocarcinoma, the most common site for metastasis is the lungs, and in lungs you will get a cannonball appearance. This is the most common appearance which you get in lung. The second most common appearance on chest X-ray is snowstorm appearance. The most common appearance is a cannonball appearance. This is a cannonball appearance on chest X-ray, right? And whenever lungs are involved in choriocarcinoma, that means it is stage 3 of choriocarcinoma. The second most common site for metastasis is vagina. In vagina, the most common site is the suburethral location. So patient can come to you with suburethral nodule also. So if they ask you suburethral metastasis is seen in which cancer, you're going to say it's seen in choriocarcinoma, right? Then the metastasis can occur in liver and brains, and whenever metastasis occurs in liver and brains, that is called as a high-risk choriocarcinoma, right? Now, in choriocarcinoma, you should remember that choriocarcinoma is a very, very chemosensitive tumor. So even if it is stage 1 or 2 or 3 or 4, whatever is the stage, you can give them chemotherapy. Now, the type of chemotherapy is going to differ if it is a low-risk choriocarcinoma or if it is a high-risk choriocarcinoma. In low-risk choriocarcinoma, you give a single agent, and that is methotrexate, and you follow up these patients for 12 months. Whereas in a high-risk choriocarcinoma, you give a Bagshaw regime or the EMACO regime, that is a multi-drug therapy, and you follow up the patients for 24 months, that is 2 years, right? Now, what are the things which show that this patient is belonging to high-risk choriocarcinoma? Number 1, if age of the patient is more than 40 years, right? That's number 1. Number 2, if her HCG levels are more than equal to 10 to the power of 5, that's number 2. Number 3, if her antecedent pregnancy was a normal pregnancy. So, if choriocarcinoma follows a molar pregnancy, that's a low-risk choriocarcinoma. But if choriocarcinoma happens after a normal delivery, after a normal full-term pregnancy, then that's a high-risk choriocarcinoma. And if you are detecting choriocarcinoma 12 months later than the antecedent pregnancy, that also makes it a high-risk choriocarcinoma. If the metastasis in choriocarcinoma is occurring in the brain or in the liver, that is high risk. If choriocarcinoma is metastasizing to lungs and liver, lungs and vagina, which is the most common site, that is a low-risk choriocarcinoma. If it is metastasizing to liver and to brains, that's a high-risk choriocarcinoma. If the number of metastases are more than 8, then that's a high-risk choriocarcinoma. And if patient has received, prior to this chemotherapy, she has received any form of multi-drug chemotherapy, then this type choriocarcinoma becomes a high-risk choriocarcinoma. And in all high-risk choriocarcinomas, you are going to use a multi-drug regime, EMACO regime, or the Backshaw regime, right? So this is in short about the molar pregnancies. So let's see our question. What the question was? The question was, what is the possible cause of choriocarcinoma after H-mole? Is all except, right? Now, rising HCG, yes, that's a possible cause. Cause means they are asking for a possible risk factor for choriocarcinoma after molar pregnancy. And in risk factors, if you remember, I told you that the risk factors are if age is more than 40 years, if HCG levels are more than equal to 10 to the power of 5, if size of the uterus is more than the period of gestation, and if there are big theca lutein cysts, right? So more theca lutein cysts, yes. Increase in the uterus size, yes. Now, suburethral nodule. Suburethral nodule is a presentation of choriocarcinoma, right? So if out of the 4 I have to exclude one, I'm going to exclude suburethral nodule. Now, some of the students who have recalled this question from AIIMS, they said that here it was not rising HCG, it was declining HCG. Now, if the question is, the options are same, but it is declining HCG, in that case, you are going to include suburethral nodule in your answer and you are going to exclude declining HCG. But if this is the question per se, then you are going to exclude suburethral nodule only on the basis that suburethral nodule is a presentation of choriocarcinoma. It's not a possible cause of choriocarcinoma, right? Okay, let's see question number 14, a very confusing question. What should be the time of termination of pregnancy of a female with insulin dependent diabetes? So let's talk about diabetes in females now. Now, in diabetes, we know that there can be overt diabetes or there can be gestational diabetes. Gestational diabetes is basically due to insulin resistance, and insulin resistance is most commonly seen during 24 to 28 weeks of pregnancy, and it is due to the hormone HPL. And that is why gestational diabetes patients, they do not show congenital malformations, because in gestational diabetes, the levels of glucose, they increase after 24 to 28 weeks of pregnancy. Right? And now the criteria for diagnosis of gestational diabetes which we follow in India is the DIPSI criteria, which was given by the Diabetes in Pregnancy Study Group India. As per this criteria, all pregnant females, they should have this test done for gestational diabetes, number 1. Number 2, this test should be done whenever the patient comes to you. Whenever it is her first antenatal visit, you are going to do this test. And number 3, fasting is not needed for this test. What you do is, whenever a female comes to you at her first antenatal visit, you are going to give her 75 grams of glucose, right? And after giving her 75 grams of glucose, after 2 hours, you are going to check her blood sugar levels. Now, after 2 hours, if her blood sugar levels are more than equal to 140, that means this patient has gestational diabetes, and if her levels are more than equal to 200, then that means it is a case of overt diabetes. If the levels are between 120 to 140, then that's a glucose intolerance. Right? Now, whenever you diagnose a patient with gestational diabetes, the first step what you have to do is you have to advise them diet modification, and this diet modification should be followed for 2 weeks with the following goals in mind: that the fasting blood sugar should come back to less than 95, 1 RPP should become less than 140, 2 RPP should become less than 120, and her HbA1c should become less than 6.5. Now, if these goals are not achieved within 2 weeks, then you are going to put the patient on the drug of choice of diabetes, and that is insulin. In case of gestational diabetes, although the drug of choice is insulin, you can give them metformin and glyburide also, right? That is in gestational diabetes. In overt diabetes, metformin and glyburide are also contraindicated. Now, when we are talking about metformin, you have to remember that metformin, it is not teratogenic during pregnancy, right? Now, let's talk about overt diabetes. In overt diabetes, as I told you, that congenital malformations are seen in overt diabetes. The most common congenital malformation which you get that belongs to the system, cardiovascular system, followed by the central nervous system. In cardiovascular system, it is the ventricular septal defect, and in central nervous system, it is the neural tube defect, right? The most specific congenital anomaly, if they ask you, the most specific is sacral agenesis, which is also called as the caudal regression syndrome. If they ask you the most specific cardiovascular anomaly, that is the transposition of the great vessels or the transposition of the great arteries. Best test which can predict congenital malformations in babies of diabetic mothers, that is HbA1c. And if HbA1c is less than 6.5, then there is no risk of gestational diabetes, there is no risk of congenital malformations in the baby. And if HbA1c is more than 9%, then the chances of congenital malformation in an overt diabetic mother are 15%, right? Best diagnostic test for congenital malformation. Now, the predictive test was HbA1c. To diagnose congenital malformation, the best test is level 2 ultrasound, which is also called as TIFA. That is targeted imaging for fetal anomalies, right? This level 2 ultrasound should be done in all pregnant females, right? So if they ask you whether TIFA should be done in gestational diabetes, yes, it should be done in all pregnant females between 18 to 20 weeks to detect congenital malformations. The drug of choice for overt diabetes is also insulin. As I told you, in overt diabetics, you do not give oral hypoglycemic drugs. They are contraindicated, right? Now, let's talk about the obstetrical management. Now, if there is a gestational diabetic patient who's controlled on diet, then ACOG says that the time of delivery should be more than equal to 39 weeks and it can go up till 40 weeks plus 6 days, right? Now, if there is a gestational diabetic patient who's controlled on insulin, then the time of delivery is more than equal to 39 weeks and it has to go up till 39 weeks plus 6 days. In either case, you have to remember that whether it is gestational diabetes which is controlled on diet or whether it is gestational diabetes controlled on insulin, the time of delivery is more than equal to 39 weeks, right? Now, in case of overt diabetes, the time of delivery is between 37 weeks to 37 weeks plus 6 days. Now, as far as the answer to this question is concerned, what should be the time of termination of pregnancy of a female with insulin-dependent diabetes? The best answer should have been 39 weeks. But since 39 weeks is not given, we are going to mark the answer as 40 weeks. Why can't we mark the answer as 38 weeks? So, this is what the texts have to say. Early term delivery 37 weeks or 38 weeks is not indicated in an uncomplicated gestational diabetes with well-controlled glucose levels, as the risk of stillbirth is low, while the neonatal morbidity rates are increased at this gestational age, right? So, whether you are managing the patient on insulin or on oral agents, you are going to deliver the patient at 39 weeks, but since 39 weeks is not given, I am going to mark the answer as 40 weeks. I cannot mark the answer as 38 weeks because the texts say that it is not indicated, right? Now, however, if a concomitant medical condition, example hypertension, is present, in that case, delivery should be considered prior to 39 weeks. So, in diabetic patients, gestational diabetes, if hypertension would have been present, then I would have considered delivery at 38 weeks. But since the question is not telling me hypertension, so I am going to do the delivery at 40 weeks. Clear? Now, ACOG suggests delivery at 39 weeks, 0 days to 39 weeks plus 6 days of gestation for a woman with gestational diabetes well controlled with medication, right? So, as I told you, ACOG is saying from 39 weeks to 39 weeks plus 6 days is the ideal time to deliver a pregnant female who is on insulin, right? But for that particular question, you are going to remember the answer is 40 weeks, right? Then in the first trimester, another way of screening is that you do an ultrasound, and in ultrasound you are going to look at the nuchal translucency. Nuchal translucency is a sonographic appearance of the subcutaneous tissue which is present below the neck. So, over here, if you look, this over here is the nuchal translucency, right? Now, this nuchal translucency, whenever you are measuring nuchal translucency, you have to measure it in the mid-sagittal plane, number one. Number 2, the head should be in neutral position. Neither it should be flexed, neither it should be extended. Number 3, the nuchal translucency is measured between 11 to 13 weeks of pregnancy and up till 13 weeks plus 6 days. You can measure the nuchal translucency. That is the best time to measure it. And if nuchal translucency is more than equal to 3 millimeters, right, then that indicates that yes, there is a problem in the fetus. And what can be the problem in the fetus? Number 1 problem in the fetus, if there is increased nuchal translucency, is trisomy 21, that is Down syndrome, followed by monosomy X, in other words, the Turner syndrome, and third is the cardiovascular problems, the congenital heart diseases, right? So, the differential diagnosis of nuchal translucency is cystic hygroma. In cystic hygroma also there is collection of fluid, but that collection of fluid will be a little more collection of fluid and it will be widespread, right? So see here, there is more fluid here and it is not localized, it is a little more widespread, right? That's a cystic hygroma. Now, cystic hygroma is a better marker for aneuploidy than nuchal translucency, and if you are getting cystic hygroma in the first trimester, then the most probable diagnosis is Down syndrome. And if you are getting cystic hygroma in the second trimester, then most probably it is a case of Turner's syndrome, right? So this is about the first trimester screening for Down syndrome. Then let's talk about the second trimester screening. In second trimester also you can go for biochemical tests and you can go for ultrasound. In biochemical test in the second trimester, you go for a quadruple test or a quad test in which you are going to measure 4 variables. Number 1, you are going to measure the alpha fetoprotein levels. Number 2, you are going to measure unconjugated estrogen, estriol, E3. That is something which you have to remember. Number 3, you are going to measure HCG levels, and number 4, you are going to measure inhibin A. Now, as I told you, in case of Down syndrome, all the biochemical markers are decreased except H for HCG, H for high. Similarly, I for inhibin, I for increased. So, the alpha fetoprotein levels will be decreased, the E3 levels will be decreased, HCG would be increased, and inhibin A levels will be increased in case of Down syndrome. If you are not measuring inhibin levels and you are measuring only the first 3 variables, then that is called as triple test. But these days we do not do triple test, we do a quadruple test. Now, in the second trimester also you can go for ultrasound, and you are going to look at the soft tissue markers. If 2 or more than 2 soft tissue markers are positive, then that indicates Down syndromes, and these soft tissue markers are number 1, nuchal skin fold thickening. Now, it's not nuchal translucency which you are going to measure, you are going to measure the nuchal skin fold thickening, and if it is more than equal to 6 millimeters, then you say that there are chances of Down syndrome. Number 2, short femur. Number 3, short humerus. Number 4, you can get an echogenic bowel. Number 5, an echogenic cardiogenic focus. Then a cystic hygroma and absent nasal bone. Very, very important, right? So, if any 2 or more than 2 markers are positive, then you say that yes, it is Down syndrome. Now, if you are doing first trimester as well as second trimester screening, that is called as an integrated approach, right? Now, screening is, suppose what are you going to do when screening comes out to be positive? Now, whenever screening comes out to be positive, the next step is you have to go for a diagnostic test. Either you can go to a diagnostic test directly, and the diagnostic test is karyotyping, right? Or what you can do is you can do a secondary screening test. The secondary screening test is you can check the cell-free fetal DNA, right? Now, this cell-free fetal DNA is a secondary screening test. Number 1, remember that it is not a diagnostic test. It is a very expensive test. And cell-free fetal DNA, which is a non-invasive prenatal test. So, it can come also as NIPT. It's a non-invasive prenatal test. Now, this cell-free fetal DNA is present in the mother's blood, and you can test this from the mother's blood, but then it's not a very good test because it is expensive and still it is a screening test. It is not diagnostic, and it can test only for certain anomalies, like it can test for trisomy 13, trisomy 18, trisomy 21, and for monosomy X. It is not available for all the aneuploidies, right? Now, whenever cell-free fetal DNA comes out to be positive, then definitely you have to go to the diagnostic test, and that is karyotyping. Another thing is what you have to remember about Down syndrome is what is the most common cause for Down syndrome, the most common reason for Down syndrome. Most common reason for Down syndrome is the non-disjunction of chromosomes. The other reasons for Down syndrome could be that it is a translocation of chromosomes, or it could be due to mosaic, but they are not the most common reasons. The next very important question is, suppose there is a female who comes to you and she says that previously she had a Down syndrome baby and now she wants to know what are the chances of recurrence of Down syndrome in the next pregnancy. For that, you are going to do a karyotyping of the baby who has Down syndrome, and you are going to see that why that baby got Down syndrome. If that baby had Down syndrome because of balanced translocation of chromosomes, which is translocation between chromosome number 21 and 21, then you are going to inform that lady that the chances of recurrence of Down syndrome are 100%. That means every time she conceives, she is going to have Down syndrome. That's very, very important. For all the other cases of Down syndrome, whether that Down syndrome was due to translocation or whether it was due to due to non-disjunction or whether it was due to mosaic, the chances are around 1 to 4%, right? Then, when I am saying that you have to do a karyotype, then for material for karyotype, how do you obtain it? In the first trimester, the material for karyotyping is obtained by chorionic villi sampling, where the study material is the chorionic villi. Chorionic villi sampling, it is done at more than equal to 10 weeks. The most common time for doing chorionic villi sampling is 11 to 13 weeks. Now, if you have to do karyotyping in the second trimester, then the material for karyotyping is obtained by amniocentesis. The amniocentesis, it should always be done at more than equal to 15 weeks of pregnancy. Best time to do amniocentesis is 16 to 18 weeks, right? Now, between amniocentesis and chorionic villi sampling, amniocentesis is more safe because the chances of fetal loss with amniocentesis are less than 0.5%, whereas with chorionic villi sampling, the chances are 1%. If they ask you what is the most common complication of chorionic villi sampling, you are going to say it is fetal loss. But if they ask you what is the most common complication of chorionic villi sampling done at less than 9 weeks, right? Chorionic villi sampling should never be done at less than 10 weeks. And if they ask you what is the most common complication of chorionic villi sampling at less than 9 weeks, you are going to say it's oromandibular limb defects, right? Let's talk about a few infections during pregnancy. One of the very important infections is chickenpox in pregnancy or the varicella in pregnancy. Now, the most common time for varicella transmission during pregnancy is 13 to 20 weeks. Very recently, this question was asked. If a pregnant female, she acquires in chickenpox at less than 20 weeks, then the baby will have the congenital varicella syndrome, and congenital varicella syndrome is an indication for doing MTP. If a pregnant female acquires chickenpox more than 20 weeks, then the baby will not have any congenital varicella syndrome. Now, the problem comes if a pregnant female has clinical manifestations of chickenpox at 5 days before delivery. So, if a patient is having manifestations of chickenpox 5 days before delivery or 2 days after delivery, then that's also very dangerous, because then the chances of neonatal varicella infection are very, very high. And neonatal varicella infection is very dangerous because it manifests like hepatitis, pneumonitis, right? So, the most common time of acquiring neonatal varicella infection is if the mother is getting chickenpox in manifestations of chickenpox 5 days before delivery or 2 days after delivery. In all such cases, the drug of choice for the baby is IV acyclovir. Again, the drug of choice for a pregnant female with chickenpox is also acyclovir. Now, suppose there is a pregnant female who comes in contact with a patient of chickenpox. In such cases, you have to give varicella immunoglobulin to the pregnant female within 96 hours of exposure. But yes, if suppose she doesn't come to you within 96 hours of exposure, you can give varicella immunoglobulin up till 10 days after the exposure, right? Now, for group B streptococcal infection, what you have to remember is that you have to do a universal screening in all pregnant females for this infection at 35 to 37 weeks, right? The drug of choice for prophylaxis against GBS infection is penicillin, and the alternative is, suppose if the patient is having sensitivity to penicillin, then the alternative is ampicillin, which you have to give 2 grams IV followed by 1 grams 4 to 6 hours up till delivery, right? So, this is the prophylaxis for group B streptococci infection. Then, if a patient has toxoplasma in pregnancy, now in toxoplasma, you have to remember that the most common time for transmission of toxoplasma to the baby is in the 3rd trimester at around 36 weeks of pregnancy, and that time it results in preterm labor. But the most severe infection is going to occur if a mother acquires toxoplasma in the 1st trimester. So the maximum time of transmission is the 3rd trimester. Most severe infection occurs if mother acquires it in 1st trimester. Let's talk about the treatment of toxoplasma in pregnancy. Now, for treating toxoplasma in pregnancy, we have 2 types of drugs. One is the pyrimethamine and sulfadiazine, and the other one is sulfasalazine. Sulfasalazine, it does not cross the placenta. Pyrimethamine and sulfadiazine, they can cross the placenta and they can be used for treating fetal infections. Now, if a female acquires infection in early pregnancy, so if they ask you what is the drug of choice of toxoplasma in early pregnancy, then it is pyramycin, because if in early pregnancy mother acquires infection, then the fetal infection will be very, very high, and just in case the fetus is found to be infected, then you are going to advise her MTP, right? So you are going to use pyramycin. Now, the drug of choice for treating toxoplasma after 18 weeks of pregnancy, that is pyrimethamine and sulfadiazine. And the drug of choice for treating fetal infection is also pyrimethamine and sulfadiazine, because pyrimethamine and sulfadiazine can cross the placenta, right? Now, drug of choice for gonorrhea in pregnancy, that is ceftriaxone, you have to give 250 milligrams intramuscularly, and you have to give azithromycin 1 grams oral stat. Now, the treatment of the partner also has to be done in case of gonorrhea, and the other thing what you have to advise the couple is that for 7 days after taking the treatment, they shouldn't have any intercourse, right? Then the drug of choice for chlamydia in pregnancy. Drug of choice for chlamydia in pregnancy is azithromycin 1 gram oral stat. The alternative is you can give amoxicillin, 500 mg TDS for 7 days. Drug of choice for bacterial vaginosis is oral metronidazole, or you can give metronidazole gel, that is 500 mg TDS for 7 days, or you can give clindamycin cream, that is 2% or cream for 7 days. But the better drug here is metronidazole. Trichomonas is the drug of choice is again metronidazole, but you give it 2 grams in a single dose. For bacterial vaginosis, you give it 500 mg TDS for 7 days, right? In candidiasis, in a non-pregnant female, the drug of choice is fluconazole, 150 mg stat. But during pregnancy, we do not give fluconazole, we give topical miconazole or cotimazole, right? Now, if they ask you what is the drug of choice for recurrent candidiasis means that if a female is having more than equal to 4 episodes of candidiasis in an year, in that case, you are going to give 150 mg of fluconazole every 72 hours, and that you are going to do for 3 doses. After that, you are going to give fluconazole 150 mg weekly for 6 months. Right? So that is how you treat candidiasis. One very, very important point which you have to remember is that in case of trichomonas and in case of bacterial vaginosis, in both these cases, the pH of the vaginal discharge, it is more than 4.5. But in trichomonas, in both these cases, you are going to get foul smelling discharge, right? In trichomonas, the color of the discharge will be yellowish, greenish color, but in bacterial vaginosis, the color of the discharge is a dirty white colored discharge. In case of bacterial vaginosis, you get clue cells in, and patient will never complain to you of itching, right? And it is not sexually transmitted. That is why in bacterial vaginosis, treatment of the male partner is not needed. Whereas in trichomonas, the patient will come to you with itching, she will come to you with dysuria, right? And the treatment of the male partner is needed because it is sexually transmitted disease. In trichomonas, you get strawberry vagina. In bacterial vaginosis, when you will do a wet smear, you are going to see clue cells, right? In clue cells, you will get vaginal epithelial cells to which the bacteria are adhered. So clue cells is diagnostic of bacterial vaginosis. As far as candidiasis is concerned, patient will come to you with complaint of she will come to you with complaint of cottage cheese like discharge, and patient will be having intense itching, and the pH of the discharge will be less than 4.5. So candida is the only organism which can survive in acidic media. That is why it is the most common vaginitis in pregnancy, right? Now, let's talk about the dose of anti-D. In all the doses, now this is the dose which I want to discuss with you. Now, the dose of anti-D at less than 12 weeks, it is 50 micrograms of if pregnancy is less than 12 weeks, it is 50 micrograms. And if pregnancy is more than equal to 12 weeks, then dose always is 300 micrograms. This 300 micrograms of anti-D is sufficient to neutralize 30 ml of fetal blood, or it is sufficient to neutralize 15 ml of RBCs, right? Now, if hemorrhage is happening more than 30 ml, right? I told you this dose is sufficient for 30 ml of fetal blood. In that case, you have to calculate the dose of anti-D by using a Clee-Hor-Betke test. Clee-Hor-Betke test is a quantitative test. On the other hand, APT test or Singer's alkali denaturation test, which is used to differentiate between vasa previa and placenta previa, that's a qualitative test. Now, if they ask you which test differentiates between fetal RBC and maternal RBC, then your answer will be the Clee-Hor-Betke test. If the question is saying which test differentiates between fetal blood and maternal blood, then your answer will be Singer's alkali denaturation test, right? Now, as far as anti-D is concerned, in abortions, if abortion is happening at less than 12 weeks, in case of threatened abortion and in case of complete abortion, in an Rh negative female, there is no need to give anti-D, right? But if abortion is happening at more than equal to 12 weeks, then for all categories of abortion, you have to give anti-D. And the dose I told you, less than 12 weeks, 50 micrograms, more than 12 weeks, 300 micrograms. Now, sometimes they do not give the dose in micrograms, they give the dose in international units. You have to remember that 1 microgram is equal to 5 international units. So 300 micrograms is equal to 1500 international units, right? Now, anti-D should be given to all pregnant females, the Rh negative pregnant females, obviously. In all Rh negative pregnant females, if their indirect Coombs test is negative, right, then it has to be given at 28 weeks. This is antepartum prophylaxis. After delivery, you have to give anti-D to Rh negative females only if the direct Coombs test is negative and if baby is Rh positive. Then only you are going to give anti-D after delivery. Again, the dose remains the same, that is 300 micrograms, right? Now, quickly let us revise, how do you manage an Rh negative pregnancy, right? Now, in Rh negative pregnancy, what we are going to do is we are going to do an indirect Coombs test. If indirect Coombs test comes out to be negative, then the only thing what you have to do is you have to give them anti-D at 28 weeks. Now, if indirect Coombs test comes out to be positive, then you have to look at the titer. If titer is less than 1:16, you don't have to do anything. You just have to follow up the patient every 4 weekly, and then you are going to deliver the patient between 37 to 38 weeks, right? But if the titer is more than 1:16, and 1:16 is the critical titer, in that case, now I am worried that the baby has got a lot of antibodies now, and so baby will be having anemia. In that case, I'm going to do 2 investigations. Number 1, I am going to do a middle cerebral artery Doppler, and I am going to do an ultrasound. Ultrasound I do to detect hydrops fetalis. Now, when I do a middle cerebral artery Doppler, if the peak systolic velocity is less than 1.5 mOM, in that case, again, nothing to worry. Simply, you have to follow up the patient. And again, you are going to follow up the patient with peak systolic velocity every 2 weeks, and you are going to deliver the patient between 37 to 38 weeks. But if suppose the peak systolic velocity is coming more than 1.5 mOM, which means that the fetus has got anemia, now it is very prudent for me to know that what is the hematocrit of the baby. So in that case, I'm going to do a chordosynthesis and I'm going to look at the hematocrit or the hemoglobin of the baby, right? If peak systolic velocity is more than equal to 1.5 mOM, in that case, what you have to do is, that means that the baby has got fetal anemia. Now you have to look at the gestational age of the baby. If baby is more than equal to 34 weeks, please deliver the baby, right? But if gestational age is less than equal to 34 weeks, in that case, you have to do a chordosynthesis, and in the chordosynthesis, if hemoglobin comes out to be less than 8, then you have to give an intrauterine transfusion. When you are giving intrauterine transfusion, that means that the baby already has antibodies, right? That means already the indirect Coombs test is positive, and whenever indirect Coombs test is positive, you do not give anti-D. So if they ask you in all of the following conditions, anti-D is given except, in that except, you have to look for intrauterine transfusions, because intrauterine transfusion means that the indirect Coombs test is positive, and now there is no use of giving anti-D, right? Now let's talk a little bit quickly about hydrops fetalis. The most common, see, hydrops fetalis, it can be immune or it can be non-immune. Most common cause of immune hydrops fetalis is the Rh isoimmunization. Apart from Rh isoimmunization, the hydrops fetalis can also be seen with if KEL isoimmunization, or if there is KID antigen, or if there is Duffy A antigen, right? Now, the most common cause of non-immune hydrops fetalis is cardiovascular disease, and the other causes are parvovirus infection, alpha thalassemia, and twin-to-twin transfusion syndrome. The ultrasound findings which are going to suggest hydrops fetalis is that there should be fluid collection in 2 or more than 2 body cavities. And what are those 2 or more than 2 body cavities? Either the baby should be having ascites, number 1. Number 2, they can be pleural effusion. Number 3, they can be pericardial effusion. And number 4, they can be subcutaneous edema. Now, this subcutaneous edema, it manifests in the form of scalp edema, and that is called as Buddha sign. So, out of pleural effusion, pericardial effusion, ascites and subcutaneous edema, any 2 should be positive to say that the baby is having hydrops fetalis. Hydrops fetalis means that the anemia or the hemoglobin in the baby is less than 5 grams, right? Now, there are 2 findings which are also seen in hydrops fetalis, but they are not a diagnostic criteria for hydrops fetalis, and that is placentomegaly and polyhydramnios, right? So, these are not a diagnostic criteria for hydrops fetalis. Read your questions very carefully when they are talking to you about what is the cause of hydrops fetalis, because they will ask you a question like this. What is the cause of all of the following are causes of non-immune hydrops fetalis except, right? So, remember, in non-immune hydrops fetalis, the answer will always be RH isoimmunization, because RH isoimmunization, it leads to immune hydrops fetalis and not non-immune hydrops fetalis. Another very favorite question of theirs is that which of the following antigens do not lead to isoimmunization. So, remember that Louis antigen, it does not lead to isoimmunization, whereas RH antigen, the Kells antigen, the Duffy antigen, all of them, they lead to isoimmunizations, right? So, this was what I wanted to you to know in OBS very quickly. Now, let us start with what I want you to know in Gynae very quickly. Okay, now let's continue with the Gynae booster. Now, the Gynae question which I want to first discuss with you is this, which is on your screens. A 76-year-old female presented with a non-healing ulcer on the labia majora for 6 months, measuring 2 into 3 centimeters with no palpable lymphadenopathy, right? There is no palpable lymphadenopathy. Biopsy shows a squamous cell carcinoma management. Okay, now let's continue with the Gynae booster. Now, the Gynae question which I want to first discuss with you is this, which is on your screens. A 76-year-old female presented with a non-healing ulcer on the labia majora for 6 months, measuring 2 into 3 centimeters with no palpable lymphadenopathy, right? There is no palpable lymphadenopathy. Biopsy shows a squamous cell carcinoma management includes. So, let's quickly talk about the vulva cancers. Now, in vulva cancer, the first thing what you have to know is that it is the 4th most gynae cancer. The most common variety of vulva cancer is squamous cell carcinoma. Right now, the second most common variety, that is around 90 to 92%. The second most common variety, which is 8 to 10%, is melanoma. The most common age group for vulva cancer is, it is seen in females more than equal to 65 to 70 years of age. And when it is seen in females more than 65 years of age, at that time, the most common variety is the keratinizing variety. The keratinizing variety of the vulva cancer, that is unifocal in origin, and the risk factors for the keratinizing variety as such are lichen sclerosis, squamous hyperplasia, and mutations in p53 gene, right? Now, if vulva cancer is seen in young females, that is in less than 55 years of age, then the most common variety which you get about the squamous cell carcinoma is the basaloid variety. So, in squamous cell carcinoma, you have a keratinizing variety which is seen in elderly females, and you have a basaloid variety which is seen in less than 55 years of females. Now, this basaloid variety, it is multifocal and it is associated with HPV infection. The most common HPV infection which is associated with vulva cancer is also HPV-16, like the cancer cervix, right? Now, the most common symptom of vulva cancer is pruritus, and the most important prognostic factor in vulva cancer is the lymph node status, right? Now, if lymph nodes are involved, then the 5-year survival rate becomes 50%, but if lymph nodes are not involved, then the 5-year survival rate is 80%. Now, if depth of invasion in the tumor or vulva tumor is less than 1 millimeters, then lymph nodes are not involved, and so if depth of invasion is less than 1 millimeter, that's also a very good prognostic sign, right? Now, before I talk to you about the management of vulva cancer, you need to know the lymphatic drainage of the vulva, right? The sentinel lymph nodes for the vulva is the superficial inguinal lymph nodes, and from the superficial inguinal lymph nodes, the drainage goes into the deep inguinal lymph nodes or the femoral lymph nodes. So, common sense tells me that if I have to do a lymph node dissection in vulva cancer, it will be inguinofemoral lymph node dissection. The other point which you have to remember is that all the structures which lie within 2 centimeters of the midline of the vulva, right? In those structures, there is crossing of the lymphatics, right? So, the lymphatics cross from one side to the other side within 2 centimeters of the midline, right? So if a tumor is lying within 2 centimeters of the midline, you will have to do a bilateral inguinofemoral lymph node dissection. But if the tumor is lying more than 2 centimeters away from the midline, then in that case, you are going to go for a unilateral inguinofemoral lymph node dissection. Now, since we are talking about lymph node involvement, let us see that in which stage which lymph nodes are involved. In stage 1 and stage 2 of vulva cancer, no lymph nodes are involved. When the lymph nodes are involved, that means the stage is stage 3 or beyond that, right? Now, if they say lymph nodes are involved, then that means it is stage 3. If they say that the lymph nodes are involved and there is extracapsular spread, then that makes it stage 3C. If they tell you that the lymph nodes are fixed and ulcerated, then that is stage 4A. And if they say that pelvic lymph nodes are involved, then you're going to say it is stage 4B, right? Now, with this background, let us talk about the management of vulva cancer. Now, in the management of vulva cancer, you have to manage two things. One is the lesion which you have to manage, and the other is the lymph nodes which you have to manage. Now, when you have to manage the lesion, you have to depend upon the staging of the lymph nodes. Now, in case of vulva cancer, the staging is clinical as well as the surgical staging. Now, simultaneously, I will also tell you the stage. Now, whenever it is the lesion is belonging to stage 1 or stage 2. Now, what do you understand by stage 1? Stage 1 means that the cancer is limited to the vulva. In stage 1, you have A and B. A means that the size of the tumor is less than 2 centimeters or the depth of the invasion is less than 1 millimeters. And B means the size of the tumor is more than 2 centimeters or the depth is more than 1 millimeters, right? Now, and stage 2. In stage 1 and stage 2, the management is the same. In stage 2, what does stage 2 means? Stage 2 means that the cancer has involved the lower parts of either vagina, lower part of the anus or lower part of the urethra. Now, in both stage 1 and stage 2, lymph nodes are not involved. Lymph nodes will be involved only in stage 3. Now, till the time it is stage 1 or stage 2, the management for the lesion is that you are going to go for a radical local excision. Right, so in your options, you are going to look for radical local excision. If radical local excision is not given, then you are because radical local excision is the other name for radical partial vulvectomy. So either it will be given as a radical partial vulvectomy, or it will be given as a radical hemivulvectomy, or it will be given as a modified radical vulvectomy. The better answer to take here is that it is a radical local excision. Now, please do not confuse radical local excision with wide local excision. Wide local excision is done in case of the pre-malignant lesions, and it is done in cases of benign conditions. Now, in wide local excision, you do not go up till the level of the urogenital diaphragm, whereas in radical local excision, you are going to go deep up till the urogenital diaphragm, right? So, this is how you manage the primary lesion in case of stage 1 and stage 2. Now, if they say that the tumor is belonging to stage 3 or stage 4, now stage 3, stage 4 means that the lymph nodes are involved. In stage 3, apart from the only thing what you have to remember is that in stage 3, whatever size they are telling you, whatever structure is involved or not involved, if lymph nodes are only involved, that is stage 3. And in stage 4, apart from lymph nodes being involved, the cancer spreads to the upper part of all the surrounding structures. So, it spreads to upper part of vagina, upper part of urethra, upper part of bladder and upper part of rectum. That is stage 4A. Stage 4B means that there is distant metastasis or the pelvic lymph nodes are involved, right? Now, till the time the tumor is belonging to stage 3 and stage 4, in that case, the main modality of treatment is chemoradiation followed by surgery. So, in stage 1 and stage 2, it is radical local excision. In stage 3 and stage 4, it is chemoradiation followed by the surgery. That is how you treat the primary lesion. Now, let's talk about how you treat lymph nodes in case of vulva cancer. Now, for lymph nodes in vulva cancer, you have to see whether the lymph nodes are palpable or whether the lymph nodes are not palpable clinically. If lymph nodes are clinically palpable, you will do a lymph node biopsy, and if lymph node biopsy comes out to be positive, in that case, you are going to do debulking of the involved lymph nodes. Right? Now, for lymph node dissection, you have to see whether the lymph nodes are clinically palpable or they are not clinically palpable. If lymph nodes are clinically palpable, you are going to do a lymph node biopsy, and if lymph node biopsy comes out to be positive, you are going to do the debulking of the involved lymph nodes. So, whatever inguinofemoral lymph nodes were involved, you will do a debulking of those lymph nodes, right? Now, if the lymph nodes are not coming out to be positive on biopsy, right? If biopsy comes out to be negative, in that case, you are going to manage them as if they were not palpable clinically, right? Now, in case of clinically non-palpable lymph nodes, you have to see whether the stage of the tumor given to you is stage 1A or any other stage. Stage 1A means that the tumor should be less than 2 centimeters and the invasion should be less than equal to 1 millimeters. Now, whenever the size of the tumor is less than 2 centimeters and invasion is less than 1 millimeters, in that case, I'm not going to do anything to the lymph nodes because the lymph nodes will not be involved. In all the rest cases, I have to do a lymph node dissection, and the lymph node dissection will be inguinofemoral lymph node dissection. Now comes whether the lymph node dissection will be unilateral or whether the lymph node dissection will be bilateral. Now, in case the size of the tumor is less than 2 centimeters, number one. Number two, it is lateral, right? It is more than 2 centimeters away from the midline and it is not clinically palpable. Till that time, I go for a unilateral lymph node dissection, that is unilateral inguinofemoral lymph node dissection. In all the other cases, we will go for a bilateral inguinofemoral lymph node dissection. So, unilateral lymph node dissection only if the size of the tumor is less than 2 centimeters. If it is lateral, right, it is more than 2 centimeters away from the midline, right, and there are no clinically palpable lymph nodes. Till that time, unilateral lymph node dissection. Otherwise, everywhere else, you are going to go for a bilateral lymph node dissection, right. So, now let us go back to our question and see what our question was saying. So, our question was saying that the cancer is on labia majora. It is 2 into 3 centimeters inside and it is not clinically palpable. The lymph nodes are not clinically palpable. Now, because it is 2 into 3 centimeters in size, that means it is stage 1B. And apart from stage 1A, everywhere I have to do a lymph node dissection, right? Now, in stage 1B, how am I going to decide for any stage, how am I going to decide the lymph node dissection? If the size of the tumor is less than 2 centimeters, right, but here the size of the tumor is given as 2 into 3 centimeters. In other words, the lymph node dissection which I'm going to do in this patient is a bilateral lymph node dissection. That is decided, right? Now, this I have decided that I'm going to do a bilateral lymph node dissection. The other thing is, now because this is stage 1B, what am I going to do to the tumor? To the tumor, the best answer would have been that I'm going to go for a radical excision, right, or I'm going to go for a radical partial vulvectomy or a radical partial or a radical hemivulvectomy or a modified radical vulvectomy. But since in the options I don't have anything like that, I'm going to say that I'm going to do a radical vulvectomy with bilateral lymph node dissection, right. So, that is what you had to know about the vulva cancer. Next question is, rectocele, cystocele and anal incontinence are due to injury to which deep structure of the perineal body? Now, before I answer this question, let us see how, if you are dissecting the perineal area from outside to inside, what are the structures which you are going to come across. See, number one, you are going to come across the skin. Then there will be the subcutaneous tissue. Then there will be the superficial fascia, the deep fascia. Deep fascia is also called as the Colles fascia, right. Now, you are going to get the superficial perineal pouch. So, this over here is the superficial perineal pouch. Then you are going to get the deep layer of the, the superficial layer of the urogenital diaphragm, right. Then you are going to get the deep perineal pouch, right, and then you are going to get the deep layer of the urogenital diaphragm, and then you are going to get a muscle which hangs down like a hammock, that is the levator ani muscle which forms the pelvic diaphragm, right. So, this is the levator ani muscle. Clear? Now, what are the muscles which are present in the superficial perineal pouch? Now, in the superficial perineal pouch, there is a muscle which is present laterally, right? And this muscle which is present laterally is the ischiocavernosus muscle. Right? Then there is a muscle which will be present here in the center like this, the bulbospongiosus muscle. And transversely, you will have the superficial transverse perineal muscle, right? Now, common sense tells me that perineal body, the structures which will be attached to the perineal body will be the muscles which will be attached to the perineal body will be those muscles which are there in the center. So, in the superficial perineal pouch, the muscles which will be attached to the perineal body, they will be the superficial transverse perineal muscle, and it will be the bulbospongiosus muscle, and yes, fibers of the muscle fibers of the anal sphincter, right? So, that will form the superficial layer of the perineal body. So, these are the muscles which will be present in the superficial layer, right? Then, the muscles which are present in the deep perineal pouch, that is the deep transverse perineal muscle and fibers of the urethral sphincter. They will form the middle layer of the perineal body, right? And then, as you will proceed up, the deepest layer of the perineal body will be formed by the levator ani muscle. Now, what you have to remember about the levator ani muscle is, levator ani muscle is formed by iliococcygeus muscle and pubococcygeus muscle. Ischio-coccygeus muscle is not a part of the levator ani muscle, right? So, if they ask you, all of the following muscles are attached to perineal body except, in that except, number 1 will be ischiocavernosus and number 2 will be ischio-coccygeus, because ischio-coccygeus muscle is not a part of the levator ani muscle, right? So, these are the two muscles which are never attached to the perineal body. Clear? Now, in order to understand this, quickly look at this diagram here. So, in this diagram, what you can see here is, this over here is the superficial perineal pouch. This is the superficial perineal pouch. In the superficial perineal pouch, we over here have the bulbospongiosus muscle, right? Then we have the ischiocavernosus muscle. You can see it is present laterally, and there will be the superficial transverse perineal muscle, right? Then you will have the urogenital diaphragm. So, this over here is the urogenital diaphragm with the superficial and the deep layers of the urogenital diaphragm, and this urogenital diaphragm, it is formed by the deep transverse perineal muscle, and then you have over here the levator ani muscle which is hanging like a hammock, right? So, now with this, let's go back to our question. The question was saying rectocele, cystocele and anal incontinence are due to injury to which deep structure of the perineal body. So, we know that the deepest layer of the perineal body, it has got levator ani muscle attached, and levator ani muscle is composed of pubococcygeus and iliococcygeus. Ischio-coccygeus is not a part of the levator ani muscle. Yes, so the answer here will be pubococcygeus. Bulbospongiosus, it is attached to the superficial layer of the perineal body, right? It is not a muscle of the deep layer. Similarly, urethral sphincter fibers are part of the middle layer. They are not a part of the deep layer, right? Next question. So, this image over here is showing iliococcygeus and this is showing you pubococcygeus. Okay. The next question is, vaginal prolapse following abdominal hysterectomy is or are caused by the damage of level 1 support, 2 or 3 support or urogenital diaphragm. So, let's quickly revise the de Lancey's levels of support. Now, the de Lancey's levels of support, see level 1 in this diagram we have made in the class also, and we have done it in the Marrow also. You can see that the level 1 support over here, this is level 1. So, level 1 is representing the apex of vagina, or level 1 is representing the cervix, that is the level 1 support. The ligaments which are supporting the upper part of vagina, that is the cardinal ligament and the uterosacral ligament, and if there is a lax in the cardinal ligament or uterosacral ligament, what is going to happen is vault prolapse. And what is vault prolapse? It is prolapse of the vaginal stump after hysterectomy, right? Then it will lead to apical prolapse, it can lead to elongation of cervix, and it can lead to enterocele. Why? Because it is related to the pouch of Douglas. So if your question is saying vaginal prolapse following hysterectomy, that means they are talking about walled prolapse. So in other words, they are saying walled prolapse is due to damage of the level 1 support, right? Let's continue with our supports. Level 2 support. Level 2 is the one which is supporting the middle part of the vagina, and the support to the middle part of vagina is provided by the arcus tendon fascia. And as you can see, if there will be a defect in the level 2, so I'm highlighting the level 2 here now. If there will be a defect in level 2, because the middle part of the vagina is related to the bladder, so there will be a cystocele, and because it is also related to rectum, so that it will lead to a rectocele, right? Then level 3 support. Level 3 support is the support which is coming to the lower 1/3 of vagina, and it is the perineal body and the muscles which are attached to the perineal body which provide support to the lower 1/3 of vagina, and you can see from the diagram that the lower 1/3 of vagina is related to the urethra. So if there is a defect in level 3 supports, it will lead to urethrocoele, and it is related to the perineum. So it will lead to the laxed perineum, right? So a defect will lead to urethrocoele or laxed perineum. So this is how you are going to answer questions related to the de Lancey's levels of support. Now, as I was telling you that walled prolapse is the prolapse of vaginal stump after hysterectomy. So many times they ask you what are the surgeries which you do to treat walled prolapse. Now, the surgeries which you do to treat walled prolapse are the uterosacral suspension. You will suspend this part, the vaginal stump which is left with the sacrum. So that is called as a uterosacral suspension, which can be done either vaginally or it can be done abdominally. This is also called as sacral colpopexy, or you can go for sacrospinous fixation, right? So these are the 3 surgeries which are done for walled prolapse, which we've already done. And I already told you that please remember that Birch colposuspension, in other words, they will not write Birch, they will say colposuspension. Now they are going to say all of the following surgeries are done in case of walled prolapse except, and in that except you will have to mark colposuspension, because colposuspension, in other words, Birch colposuspension is not a surgery which you do in walled prolapse. You do uterosacral suspension in case of walled prolapse, but you do not do colposuspension. Colposuspension is a surgery for stress urinary incontinence, right? The complete name of the surgery is Birch colposuspension. So let us quickly talk about stress urinary incontinence. What is stress urinary incontinence? It is involuntary passage of urine whenever the intra-abdominal pressure increases, right? Now, normally when intra-abdominal pressure increases, you can see here in this slide that when the intra-abdominal pressure increases, the urethra, it gets closed, right? And that is how continence is maintained. Now, just in case the bladder neck has descended down like it has happened in this case. In this case, because the bladder neck has descended down, that means there is hypermobility of the urethra. Now, in this case, whenever the intra-abdominal pressure will increase, the urethra will not close and female will have involuntary passage of urine, right? Now, for involuntary passage, stress urinary incontinence, there are 3 surgeries which are done these days. One of it is Birch colposuspension, the other is the TVTs and the TOTs. Now, as far as the colposuspensions are concerned, there were actually 2 types of surgeries which were done in colposuspension earlier. One was the Birch colposuspension and the other was Marshall-Marchetti-Krantz surgery. Both these surgeries were abdominal surgeries, and in both these surgeries what you had to do was, because the urethra had descended down, you simply had to lift the urethra, right? That is the basis for all surgeries which are done in stress urinary incontinence. Because the bladder neck has descended down, right, you simply have to lift it up. Now, in case of colposuspension surgeries, it is the proximal part of urethra which is lifted up and it is suspended to some other structure. Right? Have you understood the basis? The proximal part of urethra will be suspended up and it will be attached to some other structure so that it remains suspended. Right? In case of Birch colposuspension, you are going to suspend it to the Cooper's ligament. And in Marshall-Marchetti-Krantz surgery, it was suspended to the pubic symphysis. right? Now, because in Marshall-Marchetti-Kran surgery, it was suspended to pubic symphysis, so a very unique complication happened, and that was osteitis pubis, and that is why this surgery is no longer done. And till date, Bursch-Colpo suspension, till very recently rather, I should say, not till date, till very recently, Bursch-Colpo suspension was the gold standard surgery for treating stress urinary incontinence, right? So look here. Over here, you can see that this is the proximal part of the urethra, right? So this is the proximal part of the urethra, and in needle A, what is happening is, so this over here is a needle A. This needle A is suspending the proximal part of urethra to this red colored ligament, and this red colored ligament over here is the Cooper's ligament, right? So this is what you do in Bursch-Colpo suspension. Whereas if you look here, this needle B is going through the pubic symphysis, right? So it is suspending the proximal part of urethra to the pubic symphysis, and that is Marshall-Marchetti-Kran's surgery, right? Both these are abdominal surgeries. Now, why Bursch-Colpo suspension is not the best surgery these days? Because nowadays we have vaginal surgeries, and these vaginal surgeries are TOT and TVT. TOT is tension-free transobturator tape, and TVT is tension-free transvaginal tape. Now, these two surgeries, both these surgeries are vaginal surgeries, they are daycare surgeries, and in both these surgeries, it is the middle part of urethra which is suspended, right? Now, in case of TOT, you can see that the tape is passing through the obturator foramen, whereas in case of TVT, it is passing retropubically, right? And retropubically, that is through the space of Retzius, and that is why TOT is preferred than TVT, because in TVT, the tape passes through the space of Retzius, so there are increased chances of injuring the Santorini plexus which is present there. There are increased chances of injuring the bladder. So if they ask you which is the best surgery for stress urinary incontinence, you are going to say that the best surgery is TOT followed by TVT followed by Bursch-Colpo suspension in this order. One more thing which you have to remember is, just in case there is bleeding from the retropubic space, what you have to do is you have to put your finger in the vagina and you have to lift it up. When you lift it up, the vessels, they get compressed and the bleeding stops. That is the first thing which you have to do whenever there is bleeding from that space, right? So this is what you have to remember about the stress incontinence, the urinary stress incontinence. Okay. Now, let's see this question here. A young female has history of abortion and amenorrhea since then. Her FSH levels are 6 international units. What is the most probable diagnosis? Now, before we come to the most probable diagnosis here, let's see that how you can approach a case of secondary amenorrhea based on the FSH levels, right? So normally the levels of FSH in a female, they are less than 10 international units, and if you get a patient with secondary amenorrhea, the first thing which you have to do is you have to rule out pregnancy. In her, pregnancy should be ruled out by measuring her serum HCG levels, right? Now, all of us know that in pregnancy, the estrogen levels are high, and so if estrogen levels are high, they will have a negative feedback on FSH, and so the levels of FSH are low in pregnancy, ranging between 1 to 3 international units, right? Now, in case of secondary amenorrhea, the best test is hormonal test, and in hormonal test, you are going to do FSH, you are going to do prolactin levels, and you are going to test her TSH levels. Now, based on FSH levels, there are so many things where the questions are asked based on FSH levels. Now, all of you know that the causes of secondary amenorrhea, we can divide them compartment-wise, and the first compartment we are going to talk about is the uterus, and the first cause of the uterus, the most important cause which can lead to secondary amenorrhea is Asherman syndrome. Now, in case of Asherman syndrome, the FSH levels will be normal, the estrogen levels will be normal, and the progesterone challenge test, it is going to be negative, and estrogen and progesterone challenge test will also be negative. That is the investigation which you have to keep in mind. Estrogen levels normal, FSH levels normal, and estrogen and progesterone challenge test is negative in case of Asherman syndrome. The hint which you are going to get in case of Asherman syndrome, which will tell you that this is Asherman syndrome, is the question will say either there is history of abortion, or there is history of curettage, or there is history of postpartum hemorrhage for which the curettage was done, right? Then, The cause which is related to ovaries, number one cause is PCOS. In PCOS, the levels of FSH will be given as normal or they will be given as low. Estrogen levels will be normal. And the diagnostic point over here will be that in this case, the progesterone challenge test is going to come out to be positive. What you have to remember here, the additional points which is going to point out that yes, it is a case of PCOS is that LH levels are going to be increased. So LH levels increased, FSH levels, either they are going to say it is low or they are going to say that FSH levels are normal, right? All of us know this happens in PCOS. Plus in PCOS, you are going to get symptoms of hyperandrogenism, like you're going to get hirsutism. Now, if you are getting all this and the progesterone challenge test is coming out to be positive always and always, it means that it is a diagnosis for PCOS, right? Now, in the ovaries, it could be a case of premature ovarian failure. Premature ovarian failure is also called as primary ovarian insufficiency, or it is called as the premature menopause. The age for premature menopause is less than 40 years. Now, in case of premature menopause, the levels of FSH will be increased, the levels of estrogen would be decreased, and the progesterone challenge test will come out to be negative. The other hints which are going to point that yes, this is a case of premature ovarian failure is there will be symptoms like hot flushes, there will be symptoms like osteoporosis, right? So this is going to tell you it is a case of premature ovarian failure. Now, in pituitary, the cause could be Sheehan or it could be prolactinoma. Now, whenever the pituitary will be involved, obviously the levels of FSH will be less, the levels of LH will be less, and the levels of estrogen will be also less, right? So, it is a case of FSH less and estrogen less. So, if FSH is less, that means it is a case of hypogonadotropic, and because estrogen is less, it is a case of hypogonadism, right? So, hypogonadism is seen whenever the problem is in the pituitary. Now, that problem could be a Sheehan syndrome, that problem could be a prolactinoma. How are you going to know whether it is a Sheehan syndrome or whether it is a prolactinoma? In Sheehan syndrome, you are going to get history that patient was unable to feed her baby, and if you do an MRI, you are going to get an empty sella turcica. In case of prolactinoma, the levels of prolactin will be high here, right? The prolactin levels will be increased. On the question can say that patient was having headache, she was having visual symptoms, or she was having galactorrhea. Now, even if it is a functional problem like excessive exercise, excessive starvation, excessive eating, that is bulimia nervosa, they are all taken as functional causes of the hypothalamus. Now, if the hypothalamus is not functioning properly, again the levels of GnRH will be less, so the levels of FSH will be less and estrogen will be less. So again, hypothalamic causes are also hypogonadotropic, hypogonadism. Now, for functional causes, that is the causes which are related to hypothalamus, it is a diagnosis of exclusion which you are going to do after you have done an MRI and you have ruled out the pituitary causes, right? So this is how you approach a case of secondary amenorrhea based on the FSH levels. Now let us go back to this question which was there. A young female has history of abortion and amenorrhea, and since then her FSH levels are 6 international units. 6 international units means that the FSH levels are normal and there is history of abortion. Now, in case of ovarian failure, I told you that the FSH levels will be increased, right? Because estrogen will be less, so there will be a negative feedback on FSH, so the levels of FSH would be increased. And how much increased? More than equal to 40 international units. That is the diagnosis for ovarian failure. You should suspect ovarian failure when the FSH levels are more than equal to 20 international units. In case of pituitary failure, the levels of FSH will be decreased. Now, in case of fresh pregnancy, also the levels of FSH are low normal, that is 1, 2, 3. And so this is a case of uterine synechia, and as it is telling you there is history of abortion, so we should suspect that yes, there can be a curettage was done and patient is having Asherman syndrome, right? Now, similarly, if you have to approach a case of primary amenorrhea based on all these, right? So first let us define primary amenorrhea. Primary amenorrhea means if there is absence of menstruation by 13 years of age, in absence of secondary sexual characteristics, or by 15 years of age, irrespective of the presence or the absence of secondary sexual characteristics. Most common cause for primary amenorrhea, all of you know that it is gonadal dysgenesis. That is the best answer. And if gonadal dysgenesis is not present, then you are going to say it is Turner's syndrome, right? Now, the second most common cause is Mullerian agenesis, right? The best investigation in case of primary amenorrhea is karyotyping, right? Now, whenever you get a question on primary amenorrhea, what you have to do is, first case, you have to see case 1, that is suppose the secondary sexual characteristics are absent. So you have to see whether the secondary sexual characteristics are absent or secondary sexual characteristics are present. Now, if secondary sexual characteristics are present, then what you have to do is you have to see whether the uterus is present or the uterus is absent. If uterus is present, then that means it is a case of imperforate hymen, and the hints in the question which will tell you that it is a case of imperforate hymen is that the question will say that the patient came to you with complaints of cyclical pain in abdomen every month, and there was hematocolpos or there was hematometra, and on local examination there was a tensed bluish bulging hymen, right? Now, FSH levels in this case will be absolutely normal. Now, if uterus is absent, then it can be a case of Mullerian agenesis or it can be a case of androgen insensitivity syndrome. In Mullerian agenesis, the chromosome number is 46XX, and the hints in the question which tell you that it is a Mullerian agenesis is the question will say that the ovaries are normal, the distal part of vagina is present, FSH levels will be normal, breast will be absolutely normal and fully developed, pubic hair will also be normal and fully developed, right? So if breast and pubic hair both are developed and uterus is absent, then it means it is a case of Mullerian agenesis. In Mullerian agenesis, ovaries are normal, right? Now, on the other hand, if the question is saying that breast is developed to Tanner stage 5, but your pubic hair and axillary hair are less developed, then that means it is a case of androgen insensitivity syndrome. Another thing which will point towards androgen insensitivity syndrome is history of inguinal hernia. Now, in case of androgen insensitivity syndrome, what you have to see is whether what they are telling you about the clitoris. If they are saying clitoromegaly is present, then that means it is a case of partial androgen insensitivity syndrome. Now, in case of androgen insensitivity syndrome, you have to do a gonadectomy, but the gonadectomy is done once puberty is attained, right? That is around 14 to 16 years of age, right? Then the second case could be that there is primary amenorrhea and secondary sexual characteristics are absent. In other words, breast is absent. Now, in that case, what you have to do is you have to see the height of the patient. If height of the patient is normal, then there is a different diagnosis, and if height is short, then there is a different diagnosis. If height is short, then that means it is a case of Turner syndrome. The chromosome number in Turner syndrome is 45XO, but if height of the patient is normal, it can be a pure gonadal dysgenesis in which the chromosome number is 46XX, or it can be a Sewers syndrome 46XY. Now, whether it is Turner syndrome, whether it is pure gonadal dysgenesis, or whether it is Sewers syndrome, in all these three conditions, the ovaries are not functioning properly, right? In case of Sewers syndrome, we have the gonads are the testes, right? In all these three conditions, the gonads are not properly functioned, and that is why in all these three conditions, the levels of estrogen will be less and FSH levels will be high. They all will have female external genitalia, and in all of them, uterus will be present, but uterus would be hypoplastic. So how am I going to know whether it is a case of Turner's or whether it is a case of Sewers? What I am going to do is, first thing, karyotyping. If karyotyping is showing 45XO, then it has to be Turner's. If it is 46XY, then it has to be Sewers. The other thing is there are certain additional features which are present in Turner's, like the webbing of neck, like low posterior hairline, shield-shaped chest, which are not present in case of Sewers, right? So all these three cases, remember that the levels of FSH are high and the levels of estrogen are low. So whenever they give you a question that FSH levels are high, you have to think about any of these three conditions, and depending upon the karyotype, you are going to diagnose. Now, if in Turner syndrome, the karyotype is 45XO, that means the gonads are streak, the ovaries are streaked, you don't have to remove the streak ovaries. But if it is a case of mosaic, that means there is 45XO and 46XY. Now, whenever Y chromosome is present, then it means that you have to remove the gonads because they have high chances of malignancy. The most common malignancy which is seen in such dysgenetic gonads is gonadoblastoma, right? But if they ask you which is the most common malignant tumor which is seen in dysgenetic gonads, then you have to say it is dysgerminoma, right? Now, the other thing which can be said is if height of the patient is normal. Okay, now. So, sorry, I'm here. This over here is short stature and this is normal, right? So please don't copy incorrectly, right? Now, if height of the patient is normal, then it can also be Kallmann syndrome. Now, in Kallmann syndrome, because there is hypothalamic failure, so levels of GnRH are less, FSH is less, and estrogen is less. So, if height of the patient is coming out to be normal and her FSH and estrogen levels are low, then it is a case of Kallmann syndrome. In Kallmann syndrome, one additional feature which you get is anosmia, right? Clear? So, this is how you diagnose primary amenorrhea based on FSH levels. In case of Mullerian agenesis, in case of testicular feminizing syndrome, the levels of FSH will be normal, right? In case of Turner syndrome, pure gonadal dysgenesis and Sewers syndrome, the levels of FSH will be high, and in case of Kallmann syndrome, the levels of FSH will be low, right? Now, the next question is, which of the following is the most important marker of male infertility? Now, let's talk quickly about the semen analysis. Now, normal semen analysis, the volume, it should be more than equal to 1.5 ml. Sperm count, it should be more than equal to 39 million per ejaculate. But sperm concentration, it should be more than 15 million per ml. If sperm concentration is less than 15 million, that is called as oligospermia. If it is less than 5 million, that is called as severe oligospermia, right? Motility, it should be more than 40%. The progressive motility should be more than 32%. Morphology, as per the strict criteria, it should be more than 4%, and pH should be more than 7.2. Right? So, this is about semen analysis. Always remember that semen analysis, it has to be done when in an abstinence of, at least abstinence of 2 days should be present for semen analysis. Now, whenever on semen analysis you are getting azoospermia, you always have to check the levels of LH, FSH and testosterone. If the levels of LH, FSH and testosterone, all of them are low, that means the problem is in the hypothalamus or in the pituitary, and that is called as secondary hypogonadism, right? Now, if the levels of testosterone are low, but the levels of FSH and LH are high, that means the problem is lying in the testes, and that is a case of primary hypogonadism or primary testicular failure, and this is the most common cause of azoospermia. Right? This is the most common cause of male infertility, right? Now, if the levels of FSH, LH and testosterone, all of them are normal, that means it is a case of obstructive azoospermia. In case of obstructive azoospermia, what you have to do check is the semen volume and the fructose levels. If semen volume is normal and fructose is present, that means the block is lying above the level of seminal vesicles. And if semen volume is less and fructose is absent, that means the block is lying below the level of seminal vesicles. That means the block is in the ejaculatory duct, or it could also mean that there is bilateral absence of seminal vesicles. Now, bilateral absence of seminal vesicles is seen with bilateral absence of vas deferens in case of cystic fibrosis. Right? Now, there are 3 questions which are asked in male infertility. Number 1, cartilaginous syndrome. They ask you what is the cause of infertility in cartilaginous syndrome. In cartilaginous syndrome, the cause for infertility is asthenospermia. The cause of infertility. In Klinefelter syndrome, the cause of infertility is primary hypogonadism, and in cystic fibrosis, the cause is obstructive azoospermia. Right? Now, in case of semen analysis, the most important marker is morphology. If morphology is given, you are going to mark that as the answer, followed by motility, and then it is concentration. This is the order for in which you are going to mark the answers, right? Then, the next question. An 18-year-old female presents with an ovarian tumor. Her serum biomarkers are normal except for LDH, which is elevated. The most likely diagnosis is, okay, now very, very important for you to know a few important ovarian cancers. Ovarian cancer I have dealt with in detail in the Marrow app, right? So, everything about ovarian cancers is important. I'm going to talk only about the germ cells tumor here. Now, in germ cell tumor, as you know, that is seen in young females, and the most common malignant germ cell tumor is immature cystic teratoma, and if immature cystic teratoma is not given, then you are going to say dysgerminoma. But if they ask you which is the most common germ cell tumor, the most common germ cell tumor is dermoid cyst, right, which is a mature cystic teratoma. But if they ask you most common malignant germ cell tumor, it is an immature cystic teratoma followed by a dysgerminoma. Now, when you look at a dysgerminoma, you will see that grossly a dysgerminoma, it appears very fleshy, right, and it is lobulated and it is tan in color, right. So, you can see from here that this is a picture of a dysgerminoma. Now, a dysgerminoma is generally unilateral. It can be bilateral in 15 to 20% cases. Dysgerminoma has got the best prognosis, and the tumor markers in dysgerminoma, they are number one, the most important tumor marker is LDH, and then there are other tumor markers also like HCG and placental alkaline phosphatase. What you have to remember is alpha fetoprotein is never a marker for dysgerminoma. Alpha fetoprotein levels are not raised in case of dysgerminoma, right? Then, if they ask you which is the most malignant germ cell tumor, the most malignant germ cell tumor is the yolk sac tumor, which is also called as the endodermal sinus tumor. Endodermal sinus tumor has got the worst prognosis, and the tumor marker which is seen in endodermal sinus tumor is alpha fetoprotein and alpha-1 antitrypsin, right? HCG may be seen, but it's not the main tumor marker. Placental alkaline phosphatase is not a marker for the endodermal sinus tumor, right? Now, in the question which is given to you, they are saying that everything is normal except for LDH, and LDH is the tumor marker for dysgerminoma, right? So, here the answer will be dysgerminoma. Clear? Now, the next question. Okay, before we go to the next question, here I have an image for you for dermoid cyst. In this dermoid cyst, what you are seeing here is that hair is coming out, and over here you are seeing the Rokitansky protuberance, right? Now, dermoid cyst, if you have to remember important points about dermoid cyst, you are going to say that dermoid cyst is the most common benign tumor of the ovary. It is the most common benign tumor of the ovary in the reproductive age. It is the most common tumor of the ovary in pregnancy. It is the most common ovarian tumor to undergo torsion, right? But if they ask you what is the most common solid benign tumor, then you are going to say it is a fibroma. Now, a dermoid cyst is generally unilateral. It is bilateral in 10% cases, and dermoid cyst is mostly benign, but if it becomes malignant, and the chances of malignancy are 0.2 to 2%, if it becomes malignant at all, it becomes a squamous cell carcinoma, right? The most common malignancy which is seen in dermoid cyst is squamous cell carcinoma. Clear? Okay. Now, since we have talking about the ovarian cancer, I would also like to revise with you the staging for cancer cervix, which recently had got changed, and we have updated it in our app also, right? Now, cancer cervix staging, stage 1 cancer cervix means that the cancer is confined to the cervix, in which we have A and B. A means it is microinvasive cancer, B means it is an invasive cancer. Now, in stage A, the depth of invasion is less than 5 millimeters, right? Whereas in 1B, the depth of invasion is more than equal to 5 millimeters. What you have to remember is that in cancer cervix staging, now the horizontal spread is not taken into any account, and if cancer cervix, it spreads to the uterus, then also there is no problem. The staging does not change at all, right? Now, in case of 1A, that means the depth of invasion is less than 5 millimeters. We have A1 and A2. A1 means if it is less than 3 millimeters, and A2 means if it is 3 millimeters to less than 5 millimeters. In other words, it is 3 to 4 millimeters, right? Now, stage 1B means that the depth of invasion will be more than equal to 5 millimeters, and you have B1, B2 and B3. B1 means that the size of the tumor is less than 2 centimeters, B2 means that the size of the tumor is less than 4 centimeters, and B3 means that the size of the tumor is more than equal to 4 centimeters, right? I want you to note here that B3 is more than equal to 4 centimeters, right? Then, in case of stage 2, now the cancer is going to spread to the vagina. And what part of vagina? The upper 2/3 part of vagina. And laterally, when it is going to spread, it is going to spread to all the parametrium. Parametrium is a combined name which is given to the ligaments which are surrounding the uterus, cervix and the vagina, right? So, it is going to involve the parametrium. Now, stage 2 literally means that the cancer has involved the upper 2/3 of vagina. 2A means that parametrium is not involved. 2B means parametrium is involved. Now, in 2A, again, depending upon the size, we have 2A1 and 2A2, right? 2A1 means that the size of the tumor is less than 4 centimeters. 2A2 means that the size of the tumor is more than equal to 4 centimeters. Again, 4 centimeters is 2A2 and 1B3 was 4 centimeters. Why I am telling you to note this is because whenever the size of the tumor becomes more than 4 centimeters, then surgery is not possible and the treatment is chemoradiation, which I will be telling you just now, right? Now comes stage 3. Now, stage 3 means now the cancer has involved the lower 1/3 of vagina. 3A means that the cancer has not involved the pelvic side wall. 3B means that the pelvic side wall is involved. Now, whenever the pelvic side wall is involved, definitely it means that the ureter has to be involved. And so, if you are getting hydroureter or hydronephrosis, that means it is stage 3B. And that is why the most common cause of death in cancer cervix is renal failure, because just now metastasis hasn't occurred, but the kidneys are getting involved, right? Now, that is 3B. Now comes stage 3C. This is a new addition to the staging. Stage 3C is 3C1 and C2. That lymph nodes are involved. Whenever lymph nodes are involved, that is stage 3C. 3C1 means pelvic lymph nodes involved. 3C2 means para-aortic lymph nodes involved, right? Then comes stage 4. Stage 4 means metastasis. 4A means it is regional metastasis, that is the bladder or the rectum is getting involved, and 4B means it is distant metastasis or the superficial inguinal lymph nodes are getting involved. Remember, in endometrial cancer, in ovarian cancer, and in cancer cervix, the superficial inguinal lymph nodes are getting involved in stage 4B. And in case of endometrial cancer and in case of cancer cervix, stage 3C is the same. In both of these, 3C1 means pelvic lymph nodes involved and 3C2 means para-aortic lymph nodes involved, right? Now, how do you manage cancer cervix according to the new guidelines? Now, before I tell you how to manage the cancer cervix, now staging in case of cancer cervix, now it is clinical staging, it is radiological staging, and it is pathological staging. Earlier, radiology, the CT scan and MRI, they were not a part of staging, but now they are a part of staging. Not only are they a part of staging, in order to know whether the lymph nodes are involved or not, the best investigation is PET scan, and in order to know the parametrium is involved or not, and in order to assess the size of the tumor, the best investigation is MRI. Right? Biochemical is not a part of the staging for cancer cervix. Right? Now, let's talk about the management. In management, I'm giving you a very quick recap of the management from stage 2B to stage 4. Always and always the management is chemoradiation. That is one point you have to remember. Second point which you have to remember is whenever the tumor is more than 4 centimeters in size, then also surgery is not possible, and then also it is chemoradiation. And just now we did that in stage 1B3 and in stage 2A2, the size was more than 4 centimeters. So in 1B3 and 2A2, again it is chemoradiation. For all the others, you have to do a surgery. And what surgery? In stage, so you have to do surgery in 1A1, you have to do surgery in 1A2, you have to do surgery in 1B1, in 1B2, and you have to do a surgery in 2A1, right? Now, in case of stage 1A1, you are going to start with the lowest surgery. So, in a young female, you are going to do conization, and in an older female, you are going to do type 1 hysterectomy. In case of stage 1A1, in older females, also conization can be done, right? In case of stage 1B2, in a young female, you will do conization, or you can go for a radical trachelectomy. In case of older females, you will go to a little higher surgery, that is type 2 hysterectomy, right? Type 2 hysterectomy is also called as Wertheim's hysterectomy. Also remember that these type 1, type 2, type 3, they are based on the Pivot-Rutledge classification. We also have another classification which says that type 1 is type A hysterectomy and type 2 is type B hysterectomy. It's the same, just the name has changed. Type 1 is also now called as type A hysterectomy, type 2 is also called as type B hysterectomy, type 3 is also called as type C hysterectomy, right? Okay, so let's continue with our management. So, in case of stage 1A2, in young females, you can do either conization or radical trachelectomy, and in older females, you will do type 2 hysterectomy or type B hysterectomy, right? In case of stage 1B1, in a younger female, again, you will do radical hysterectomy. What you have to do, remember that in radical hysterectomy, you are removing 80% of the cervix, and radical trachelectomy, Radical trachelectomy, you are removing 80% of the cervix, and radical trachelectomy, right? It can be done only till the time the size of the tumor is less than 2 centimeters, right? Now, in case of stage 1B1, the size of the tumor is less than 2 centimeters, right? So, till the time it is stage 1B1, in young females, I can go for radical trachelectomy. In case of older females, I will go a little higher surgery, and that is type 3 hysterectomy now. Now, because after type 3 hysterectomy, we don't have any hysterectomy which we do for cancer cervix. So, after this, for every other stage, we are going to use a type 3 hysterectomy in older females, right? In young females beyond stage 1B1, 1B1 means that the cancer is less than 2 centimeters in size. Now, the moment it becomes 1B2, that means now the cancer will be more than 2 centimeters in size. So then again the surgery becomes same like older females, that is type 3 hysterectomy. So only thing you have to remember is that in young females in 1A1 you can do conization, in 1A2 conization, or you can go for radical hysterectomy, 1B1 radical trachelectomy, and in 1B1 radical trachelectomy. After that, always and always you are going to go for hysterectomy. Right. Similarly, in older females, you have to remember that in 1A1 you have to do a type 1 hysterectomy, or you can do a conization. In 1A2 you are going to do a little higher hysterectomy, that is type 2 hysterectomy. In 1B1 you will do a little more higher hysterectomy, that is type 3 hysterectomy, and after that type 3 hysterectomy. Right. So that clears our cancer cervix. The other thing which you have to remember in cancer cervix is how do you manage a case of pap smear, abnormal pap smears. How do you manage them? Now, whenever you get an abnormal pap smear report, right, if the lesion is visible, you will go for punch biopsy. If lesion is not visible, you will go for a colposcopic directed biopsy, right? Now, whatever the pap smear report is, if it is telling you whether it is LSIL, then also you're going to do this. If it says it is HSIL, then also you're going to do this. If it says that it is a CIN, then also you're going to do this, because pap smear is only a screening test. Now, as far as HSIL is concerned, along with colposcopy, you will have to do an endocervical curettage, right? Then, suppose if they say that the pap smear report is ASCUS, that is atypical squamous cells of unknown significance. Now, in this case, you have to do HPV DNA testing, and if HPV DNA testing comes out to be positive, then you have to go for colposcopy. This is called as reflex DNA, HPV DNA testing. Now, but if they say that it is ASCUSH, right? ASCUSH means that there are atypical squamous cells, but HSIL cannot be excluded. In that case, management is same like you go for LSIL, HSIL and CIN. So, in LSIL, HSIL, CIN or ASCUSH, it is that you have to do a colposcopy, right? In case of HSIL, along with colposcopy, you will do an endocervical curettage, right? But if report is ASCUS, simply ASCUS, then you're going to say that the management is, next step in the management is I'm going to test for HPV DNA, and if HPV DNA comes out to be positive, then I'm going to go for colposcopy, right? Everything about pap smear, the screening guidelines and how to do a pap smear, we have dealt in the app very nicely, and I want you to go back and revise all that, right? Now, let us quickly discuss a few important points on contraception. Yes, start. Okay, hi, welcome friends, welcome back to this last session of the Obs and Gynae Booster, where I'm going to talk to you about important points on contraception. Now, for important points on contraception, I want all of you to divide your page into 6 columns, right? Now, in the 6 columns, the first column is going to be about the contraception, then the second will be STD and PID, third is ectopic pregnancy, what are the chances of ectopic pregnancy with that particular contraceptive, then whether that contraceptive can be used as an emergency contraception or not, the contraindications and the uses. So, the 6 columns, number 1 contraception, number 2 STD and PID, number 3 ectopic pregnancy, number 4 can it be used as an emergency contraceptive, number 5 contraindications, and number 6 uses, right? Now, the first thing which we are going to talk about is the male condoms or the female condoms. Now, male condoms and female condoms, both of them, they decrease the chances of STD or PID. Not only the STDs and PIDs, the male condoms and the female condoms, they also prevent HIV transmission, right? Between male condom and female condom, it's the male condom which is better in preventing HIV transmission. Then because they are decreasing the chances of PID, obviously to decrease the chances of ectopic pregnancy. So they decrease the chances of ectopic pregnancy. You cannot use male or a female condom as an emergency contraceptive. The contraindications, there are no contraindications as such for condoms except if the partner is allergic to condoms. In female condoms, yes, there is one contraindication, and that is if patient is having prolapse or if there is a retroverted uterus. Right? Now, the uses. In uses, you have to remember that male and female condom, they prevent the transmission of HIV. That is one very important thing which you have to remember. Another thing which you have to remember is because they also prevent the transmission of human papilloma virus, and that is why they are helpful in decreasing the incidence of cancer cervix and the dysplasias. Right? Okay. Then the second thing which you have to, the second contraceptive which you have to remember is the Today contraceptive. Today contraceptive, it is a mushroom shaped contraceptive. Look at an image of Today. So this is a Today contraceptive, right? This is a female condom and this was a diaphragm. We are going to talk about diaphragms very shortly. So you can see that Today contraceptive, it is a mushroom shaped device which has got non-oxynol 9 in it, and it has got 1 gram of non-oxynol 9. Now this non-oxynol 9, it is a spermicidal agent. Now all the spermicidal agents, how do they act? They act by disrupting the cell membranes, right? Now this Today contraceptive, it will also decrease the chances of STD and PID, but it will not decrease the chances of HIV. Because it is decreasing the chances of STD and PID, it will decrease the chances of ectopic pregnancy. You cannot use Today sponge as an emergency contraceptive, and as far as the contraindications are concerned, it's the same in patients of prolapse and in patients of retroverted uterus. It's difficult to use Today sponge. Now, some important points which you have to remember about Today sponge is that it is inserted maximum 24 hours before the intercourse, right? So maximum 24 hours before intercourse, you can insert Today sponge, and then irrespective of the number of times of intercourse, right, it can be used, right? So once it is inserted, it will remain inserted for 24 hours, and then the number of times of intercourse, they do not matter. Right? Then you have to remove this the Today sponge within 6 hours of the intercourse. You will have to remove it, right? So this means that a Today sponge can remain in a female's vagina for maximum up to 30 hours. Right? So 24 hours you can insert it before, and you have to insert it after 6 hours. So maximum it can stay for 30 hours. Right? Now, whenever you are using a Today sponge, it decreases the chances of toxic shock syndrome. Whereas, whether you are using a female condom and you forget to remove a female condom, or if a female forgets to remove a diaphragm, that leads to increased chances of toxic shock syndrome. But with Today sponge, it is seen that the chances of toxic shock syndrome are decreased. Right? Then, let's talk about diaphragms. Now, as far as the diaphragms are concerned, diaphragms, they are not a perfect mechanical barrier, right? So whenever you are using diaphragm, you will have to suggest a female that she will have to use it along with a spermicide. Diaphragms also decrease the chances of STDs and PIDs, but they will not decrease the chances of HIV, right? Again, they will decrease the chances of ectopic pregnancy. They cannot be used as an emergency contraceptive. So this column over here is about the emergency contraceptive. It cannot be used as emergency contraceptive. It decreases the chances of ectopic, and yes, it decreases the chances of D and H. As far as the contraindications are concerned, the contraindications for diaphragm, for a female condom and for Today sponge are the same, that they cannot be used in females who have prolapse or who have a retroverted uterus, right? Now, I told you that a Today sponge, it can be inserted by a female 24 hours before the intercourse, right? But that is not the case with a diaphragm. A diaphragm can be inserted maximum up till 2 hours before intercourse. Then I told you that a Today sponge, it can remain in vagina up till 6 hours after intercourse. Within 6 hours of intercourse, you will have to remove the Today sponge. In case of diaphragm, you will have to remove the diaphragm within 6 to 8 hours of intercourse. The maximum time for which a today's sponge can remain in a female's vagina total is 30 hours, and maximum time for which a diaphragm can remain in a female's vagina is 24 hours. I told you today's sponge, it decreases the chances of toxic shock syndrome, but a diaphragm, it increases the chances of toxic shock syndrome, just in case it is forgotten, right? So that is what you had to remember about the barrier contraceptives. Now, after the barrier contraceptives, let us talk about the oral contraceptive pills. Now, in oral contraceptive pills, first thing is, how do you classify the oral contraceptive pills? The oral contraceptive pills, they are classified on the basis of the estrogen component. If you are classifying them on the basis of the estrogen content, right, then you call them as a high dose pill or a low dose pill or a very low dose pill. A high dose pill means that the estrogen content in the pill is more than equal to 50 micrograms. These pills are no longer used now, right? Low dose pills means that the estrogen content in them is less than 50 micrograms, and to be accurate, the content is 30 to 35 micrograms. If between 30 to 35 micrograms you have to choose one, you're going to choose as 30 micrograms, right? A very low dose pill means that the estrogen content is less than 20 micrograms. Now, the lowest possible estrogen content which can be there in a pill is 10 micrograms, and recently FDA has approved a pill which has got 10 micrograms of estrogen, and that is loloestrin Fe. So loloestrin Fe has got 10 micrograms of ethinyl estradiol, right? This is how you classify the pills on the basis of estrogen content, right? A high dose, low dose, very low dose pill. But if you are classifying OCPs on the basis of what progesterone is present, then it is classified either as a first generation pill or a second generation pill or a third generation or a fourth generation pill. That depends upon the which generation progesterone you are using in it, right? If you are using first generation progesterone, that becomes a first generation pill. If you are using second generation progesterone, that becomes a second generation pill. If you are using a third generation progesterone, that becomes a third generation pill. Now, if you remember my lecture on hormones, I told you that as the generation increases of progesterone, the synthetic progesterone, as the generation increases, the androgenic side effects, they keep on decreasing, right? So a third generation progesterone will have least androgenic side effects, and in third generation we have three progesterones. Number one, we have desogestrel, number two, we have gestotine, and number three, we have norgestimate. All these three are the third generation progesterone, right? So the third generation progesterones are desogestrel, gestodine, and the norgestimate, right? Now, a pill which has got any of these third generation progesterone, that will be called as a third generation pill, right? Now, fourth generation progesterones are anti-androgens, right? For example, spironolactone, right? So you can have either cyproterone acetate or you can have drospirenone. So any pill which has got drospirenone or cyproterone acetate, that becomes a fourth generation OCP pill, right? Examples of fourth generation pills which are available in the market, they are Yasmin and Diane 35. Now, why are the third generation and fourth generation pills important? They are important because I am telling you that as the generation increases, the androgenic side effects decrease, right? So suppose a PCOS patient comes with irregular cycles, and we know that whenever the cycles are irregular, you have to give them OC pills. Now, in that case, the pill which I am going to give her should belong to third generation or a fourth generation, right? Otherwise, as it is, she has hirsutism, as it is, she has a lot of androgens, and if these progesterones also bring about androgenic side effects, then there will be a problem, right? So that is about the classification of the pills based on the what type of progesterone is present, Right? Now, the next important thing is, what is the main mechanism of action of an OCP pill? The main mechanism of action of a pill is it brings about an ovulation. And how does it do that? Because it has got progesterone. Progesterone will have a negative effect on LH, and that is why the LH surge will be absent, and so it will bring about an ovulation. That's the main mechanism of action. Although there are other mechanisms of actions also, because OCPs, they have got estrogen also. So estrogen will have a negative feedback on FSH, and that is going to inhibit folliculogenesis. But that is not the main mechanism of action. Similarly, because OCPs, they have got progesterone. Progesterone will also bring about thickening of the cervical mucus, but then that's not the main mechanism. If they ask you main mechanism, you're going to stick to it, that it brings about an ovulation, right? Now, let's talk about the chances of PID and STD with an OCP pill. Now, OCPs, they decrease the chances of PID because they have progesterone, and progesterone will bring about the thickening of cervical mucus. But somehow it has been seen that if you get PID in a patient of in a person who's using OCP pill, then it will be either chlamydia or candida. So it decreases all PIDs, but it is seen that subclinical infections with chlamydia and candida are there in patients who are using the pills, right? Now, as far as the chances of ectopic pregnancy are concerned, a very important thing is that all contraceptives, they decrease the chances, the absolute chances of ectopic pregnancy. Why? Because all contraceptives, they decrease the chances of pregnancy. Any kind of pregnancy, the chances are decreased by the contraceptive agents. The problem is that when these contraceptive agents fail, their failure results in ectopic pregnancy, right? So it is not the use which results in ectopic pregnancy, it is their failure which results in ectopic pregnancy. So amongst all contraceptive pills, if there is failure of OCPs, right, then the chances of ectopic pregnancy are least, right? So if they ask you which contraceptive is associated with least chances of ectopic pregnancy, it is the pills, right? Now, can pills be used as emergency contraceptive? Yes, the pills can be used as an emergency contraceptive, and it is the USPs method. According to the USPs method, in order to be used as an emergency contraceptive, you have to give 100 micrograms of estrogen once and then followed by 100 micrograms after 12 hours. Now, common sense tells me that because high dose pills, they have got 50 micrograms of estrogen. So if you are using USPs method with a high dose pill, it will be, you will have to give 2 pills just now, and then after 12 hours, you will have to repeat another 2 pills. But if you are using low dose pills, right, in low dose pills, you will have to give 4 pills just now, and then after 12 hours, you will have to give 4 pills. Similarly, if you are using very low dose pills, which have got less than 20 micrograms, you are going to give 5 pills stat, and then after 12 hours, you are going to give 5 pills. So yes, OCPs, they can be used as an emergency contraception. What are the contraindications of OCPs? The contraindications of OCPs, you can remember by the mnemonic. Banks have various schemes to provide home loan during May, right? Banks have various schemes to provide home loans during May, where B stands for if there is a history of breast cancer, B, banks, right? Banks have. H stands for hypertension. So if the female's BP is very high, that is more than 160 by 110. Banks have various. V stands for undiagnosed vaginal bleeding, right? Schemes. S stands for a smoker whose age is more than equal to 35 years. So if age of the patient is more than 35 years and she is a smoker, then that's an absolute contraindication for using OCPs, right? All these, what I'm telling you, are absolute contraindications, right? Schemes 2. T stands for if there is history of thrombosis, right? Now, that history of thrombosis can be in the form of history of a stroke or a cerebrovascular disease, or it can be in the form of coronary artery disease. Then provide. P stands for pregnancy, right? Banks have various schemes to provide home. H stands for high cholesterol levels or high triglyceride levels. Loans. L stands for liver disease. D stands for during, for diabetes with vasculopathy. And May. M stands for migraine with aura. So these are all absolute contraindications for using OCPs. Either they will ask you a question like what are the absolute contraindications for using OCPs, or they can ask you what are the WHO category 4 contraindications for OCP. So whether they say acute or whether they say WHO category 4, that's one and the same thing, right? Now, when we talk about OCPs, they are the drug of choice as a contraception after H-mole evacuation. You are going to use OCPs as a contraceptive agent. They are also of choice in a young married couple who are living together. They are also the drug of choice for hirsutism. OCPs are the drug of choice for irregular cycles. Right? Now, OCPs are also used in case of primary dysmenorrhea, right? Because they bring about an ovulation, and because they will bring about an ovulation, we know that anovulatory cycles are painless, so they are used in the management of primary dysmenorrhea. They are used in irregular cycles. That is because whenever you give OCPs, you are going to give OCPs from day 1 of the cycle. That is the perfect way to start an OCP. So please give a heading somewhere, how to start an OCP. Whenever you have to start an OCP, the best time to start an OCP is from day 1 of the cycle. But you can start it at any time less than day 5. Now, if a female is starting at any time less than day 5, she doesn't need any backup contraceptive method. But if a female is starting after day 5, she needs a backup method of contraception, right? So, whenever you are giving OCPs, you give OCPs from day 1 of the cycle, right? Now, from day, and an OCP pill, it has got 21 tablets, right? Now, for 21 days, the patient is going to take OCPs. Now, till the time she is taking those pills, till that for 21 days, the levels of estrogen and progesterone in her body will be high, right? Now, after 21 days, once the pack is over, she will stop taking the pills, right? And so the levels of estrogen and progesterone in her body will go down. And when the levels will go down, she will menstruate in a day or 2, right? And when she will menstruate again from day 1, she will start another pill, another pack, right? So this means that OCPs are used for irregular cycles to make the cycles regular, right? Now, suppose if a female was taking an OCP pill and she forgot to take a pill. Now, if a female forgets to take one pill, right, then that's not a big problem, because next day she can take 2 pills instead of 1, and she doesn't need any backup method of contraception. But if she forgets to take 2 or more pills, then that's a problem. She will have to, whenever she remembers, she's going to take 2 pills at that time, and then she will continue with 1 pill, and she's also going to use a backup method of contraception for 7 days. And in all such cases, suppose a patient has missed a pill and she comes to you with a complaint that I did not have any withdrawal bleeding after stopping the pack, right? In that case, you should get her pregnancy tested. Now, we were talking about the uses of OCPs, and I was telling you that how OCP can be used to manage irregular cycles. OCPs can be used to manage primary dysmenorrhea, right, because it makes the cycles anovulatory, and because whenever you are using OCPs, you are giving synthetic estrogen. And how much synthetic estrogen? Just 30 to 35 micrograms of synthetic estrogen. This synthetic estrogen, when you will give, it will go inside the female's body, and it is going to decrease the natural FSH. So when it will decrease the natural FSH, the natural estrogen in the female's body will decrease, right? So whatever estrogen will be there in the female's body will be just that much which is obtained from that pill. So that means that OCPs can also be used in managing all hyperestrogenic conditions of the body, right? So OCP can be used in management of fibroids, and OCPs can be used in management of endometriosis. And this is also the basis that why OCPs, they decrease the chances of ovarian cancer and endometrial cancer, because OCPs are decreasing the natural estrogen. So the cancers in which OCPs are protective, they are ovarian cancer, number 1, endometrial cancer, number 2, number 3, colon cancer, right? And number 4, it is protective in benign breast diseases, right? Then OCPs, they increase the risk of certain problems, and they increase the risk of depression, number 1. Number 2, they increase the risk of cancer cervix. Now, when you are using OCPs, then the cancer cervix which a female will have will be adenocarcinoma of the cervix. But then the moment she stops using the pills, the chances are reversed, right? And number 3, it increases the chances of gallstones, the OCPs. OCPs do not have any effect on the chances of breast cancer, number one. They do not have any effect on the chances of hepatic adenoma. They do not have any effect on the chances of hepatocellular carcinoma, and they do not have any effect on gallbladder cancer, right? So this is, and just one more thing, just in case patient was on OCP and she has become pregnant. She did not know that she had missed a pill, right? And she did not take any backup method. And suddenly when she remembered that she had stopped taking a pill, by that time she had conceived and she was again taking the pills also. Remember that if by chance a female takes OCP during pregnancy, then OCPs, they are not teratogenic. And fertility is going to return after stopping OCPs within 3 months, right? So the fertility returns very quickly after stopping OCPs, right? Now, so this is what I wanted you to know about the OCPs in general. Now, next we have to remember progesterone-only contraceptives. There are certain important points about all progesterone-only contraceptives. Now, when I say progesterone-only containing contraceptives, I am talking about the progesterone-only pills. I am talking about the progesterone implants, and I am talking about the progesterone injections. Right, I'm talking about these three categories. Now, in all these three categories, what is going to be there is what is the mechanism of action. Now, for all progesterone containing contraceptives, what you have to remember is if progesterone belongs to older generation, that is if progesterone belongs to first or to second generation, or if progesterone is present in low quantities, then the mechanism of action is that it makes the cervical mucus thick, right? But if progesterone is the new generation progesterone, the new generation progesterones, that is the third generation progesterone or the fourth generation progesterone, or if progesterone is present in high concentrations, then the mechanism of action is that they inhibit ovulation, right? In low concentration and with older generation, the mechanism of action is it makes the cervical mucus thick. With new generation and or in higher concentrations, the main mechanism of action is that they inhibit ovulation, right? Now, all progesterone containing contraceptives, they do not have any effect on carbohydrate metabolism, they do not have any effect on lipid metabolism, and they do not have any effect on coagulation profile, right? So in all those conditions where estrogen containing contraceptive was contraindicated, you can give only progesterone containing contraceptive. Now, as far as the last point which I told you was concerned, that they do not have any effect on coagulation profile, that means that progesterone containing contraceptives can be given in patients of thrombosis. But now comes a but. The but is that only progesterone only pills are given whenever there is a history of thrombosis. When we talk about implants and when we talk about injections, they are contraindicated in patients who are having thrombosis. So that is a warning which is written there on their packs, that they should not be used in patients who have thrombosis. But progesterone only pills can be used in patients who have history of thrombosis. Right? Now, all progesterone containing contraceptives, because they are going to make the cervical mucus thick anyways, so they are going to decrease the chances of PID, right? Although the main mechanism of action of the newer progesterone containing contraceptives would be inhibiting ovulation, but that does not mean that they do not make the cervical mucus thick. They will make the cervical mucus thick, but that is not their main mechanism of action, and because they are making cervical mucus thick, they will decrease the chances of PID. Now, as far as ectopic pregnancy is concerned, all progesterone containing contraceptives, if their failure occurs, there are high chances of ectopic pregnancy. Now, why is that? We know that a morula, it moves towards the uterine cavity because of the main action is because of the peristalsis in the tube. And what is a progesterone? Progesterone is a smooth muscle relaxant, right? So a progesterone containing contraceptive is going to slow down this peristalsis, and so if failure of any progesterone containing contraceptive ever happens, there are very high chances of ectopic pregnancy. Clear? Now, progesterone containing contraceptives, they are not used as emergency contraception. Just because I'm going to tell you that one of the emergency contraceptive is levonorgestrel, that does not mean you can use POP as a contraceptive, as an emergency contraceptive. That does not mean you can use implant as an emergency contraceptive. That does not mean you can use an injection as an emergency contraceptives, right? Then, for all the progesterone containing contraceptives, the side effect will be irregular bleeding. So much so that if you are using long acting progesterone containing contraceptive, the long acting progesterone containing contraceptives are the injections and the implants. Because the progesterone will be released continuously, it will lead to endometrial atrophy, and finally patient is going to come to you with complaint of amenorrhea. So initially patient will come to you with a complaint of irregular bleeding, and if you are using injections and if you are giving implants for a very long time, finally patient will have amenorrhea. Now, all the progesterone containing contraceptives, they can be used in a breastfeeding female, right? Now, the contraindications for all progesterone containing contraceptives, you can remember it by a mnemonic, that is Virat likes to play with ball, where V stands for undiagnosed vaginal bleeding, L stands for liver disease, likes to, T stands for history of thrombosis. The only exception is POPs. POPs, they can be used if there is a history of thrombosis. Virat likes to play with, there is nothing with, and B stands for if there is history of breast cancer. Now, one very important thing which you have to note here is that I told you that all progesterone containing contraceptives, they increase the chance of ectopic pregnancy if failure happens, but that does not mean that previous history of ectopic pregnancy is a contraindication for their use. Notice here that previous history of ectopic pregnancy is not a contraindication, right? So this was in general what you had to remember about all progesterone containing contraceptives. Now let us talk about specific points about progesterone only pills. Now, in progesterone only pills, if they ask you what is the mechanism of action of progesterone only pills, now because the main mechanism, mostly it is the older generation pills which are available. So if they ask you what is the main mechanism of action of progesterone only pills, you are going to say that the action is thickening of the cervical mucus, right? But the progesterone only pill which is available in India, that is Cerazette, right? This Cerazette has got desogestrel, right? And desogestrel is a newer progesterone. So if they ask you what is the mechanism of action of progesterone only pill available in India, right? Or if they ask you what is the mechanism of action of the newer progesterone only pills, then you are going to say it inhibits ovulation. If the simple question is mechanism of action of progesterone only pills, then you are going to say that it makes the cervical mucus thick. Now, the older generation containing progesterone only pills, as I told you, their main mechanism of action is making the cervical mucus thick. The other problem with older generation POPs is that, see, all POPs, they have a very short lifespan. That is why you have to give all POPs exactly at the same time every day, right? So if a female took an older generation pill at 9 o'clock in the morning today, then next day also she has to take it at 9 o'clock, right? Just in case she forgets to take it at 9 o'clock, the window period is 3 hours. Within 3 hours of the time she has to take it. So by 12 o'clock, if she takes it, it's okay. But if she forgets and she takes it at 2 o'clock, then you will have to tell the female that for next 48 hours, she will have to use some other method of contraception, right? Then, in case of newer pills, that is which includes the Cerazette, the window period is 12 hours, right? So if she forgets to take the pill at 9 o'clock tomorrow morning, she can take it till 9 o'clock tomorrow night, right? Now, progesterones, the POPs are the contraceptive of choice in a lactating female. Although I know that in your PSM lectures, maybe you have been told that the contraceptive of choice in a breastfeeding female is IUCDs. But our Obs and Gynae books say that the contraceptive of choice in a lactating female is progesterone only pill, and the reason which they give is that IUCDs, when you insert them in the immediately after childbirth, they have increased chances of expulsion, right? So they say that the contraceptive of choice in a breastfeeding female is progesterone only pill. That is all what you have to remember about progesterone only pill. Now let's talk about progesterone injection, and the injection which you have to remember, very important, is the DMPA injection, that is the Depo-Provera injection. This Depo-Provera injection, it has got 150 milligrams of medroxyprogesterone acetate. So the progesterone present is medroxyprogesterone acetate, and it has got 150 milligrams. And this injection has to be given every 3 monthly, right? A delay of 4 weeks is acceptable in case of DMPA. Now this injection, it should be given within 7 days of the menstrual cycle, and it is effective within 24 hours, right? Now, very important point which you need to know about DMPA is that very recently DMPA has been included in the National Family Planning Program by the Government of India, and it is being distributed free of cost in 8 high-risk states by the name of Injection Antara. Right? So DMPA is by the name of Antara is being distributed free of cost by the Government of India in 8 high-risk states. Very important for your exams, right? Now, apart from everything which I told you about progesterone only contraceptives, you have to remember that DMPA has 2 advantages and 2 disadvantages. The 2 advantages of DMPA is it decreases the sickling in case of sickle cell anemia, and it decreases seizure frequency. So if someone asks you what is the contraceptive of choice in a patient with sickle cell anemia, you're going to say DMPA. Similarly, if they ask you what is the contraceptive of choice in an epilepsy patient, you are going to say it's DMPA. But the 2 disadvantages of DMPA are that it decreases the bone mineral density significantly, right? And number 2, there is delay in the return of fertility, right? Now, fertility on an average after stopping DMPA injection, it returns within 12 months. That is within an year of female's fertility returns. But maximum it can take up to 18 months for her fertility to return. Now, if I ask you what is the mechanism of action of DMPA, now you can see here that in DMPA, 150 milligrams of medroxyprogesterone acetate is present. It means that it has got very high concentration of progesterone. And I told you that whenever progesterone is present in high concentrations, the mechanism of action becomes it inhibits ovulation. Right? So it can inhibit ovulation, that is its main mechanism of action. Very important DMPA injection for the upcoming exams, right? Then let's talk about the IUCDs, the copper IUCD and the levonorgestrel IUCD, that is Mirena. So let me show you, before that, let me just show you a few images. So this I showed you, this is a today's sponge, right? This was a female condom, and this over here is a diaphragm, right? Then, now this over here is copper T380A. Now, why am I calling it copper T? Because it is T-shaped, right? It is T-shaped, that is why I'm calling it as copper T. Now, it has got copper wire around it, and the surface area of the copper wire is 380 millimeters square, right? That is 380 millimeters. That is the surface area of the copper wire, right? Now, why it is called as A? It is called as A because here not only is the copper present on the vertical limb, copper is also present on the arms of this copper T. That is why it is called as copper T380A, right? And this copper T380A, it is coated with barium sulfate, and that is why it is visible radiologically, right? Now, this copper T380A, it is also called as Paragard, right? Now, in copper T380A, one thing also you will note that over here at the end, there is a 3 millimeters ball which is present, right? This 3 millimeter ball will prevent cervical perforations, right? And there is a monofilament thread which is hanging from here. This monofilament thread which hangs from here, it helps in easy removal of copper T, and it makes a female, it ensures to a female that yes, the copper T is in place, right? So this is how you identify a copper T. You are going to see copper on the vertical limbs and on the arms. The moment you see it is on the arms, it is copper T380A. Whereas when we talk about Mirena, this is an image of a Mirena. In the image, you can see that here there is no copper wire. Again, you can see over here a thin ball, and you can see of the threads which are hanging out, right? Now this Mirena, it is a hormone releasing device, right? Copper IUCD, it belongs to second generation IUCD, and Mirena or any hormone releasing device, it belongs to third generation IUCDs, right? Now, in case of Mirena, the hormone which it has got is levonorgestrel, and this levonorgestrel is contained only in the vertical limb, right? Now, the total amount of levonorgestrel which is present in Mirena is 52 milligrams. Right now, let's divide your page. On one side write copper T, on one side write Mirena. In copper T, you will write that copper T 380A is known as Paragard. Mirena, it contains levonorgestrel and it is called as LNG20. Why it is called as LNG20? I'll tell you shortly, right? Then, the surface area of the copper wire in copper T380A is 380 millimeters square. The total amount of levonorgestrel which is there in Mirena is 52 milligrams. Now, the rate of release of copper by a copper T is 50 micrograms per day, whereas the rate of release of levonorgestrel by Mirena is 20 micrograms per day. Right? That is why now you understand why it is called as LNG20, because it releases 20 micrograms of levonorgestrel per day. The approved lifespan for copper T380A is 10 years and for levonorgestrel it is 5 years. But if they ask you for how long is copper released or for how long is the hormone released, so copper can be released by the copper T by 12 years, whereas hormone can be released by Mirena for 7 years. But their approved lifespan for a copper T is 10 and approved lifespan for Mirena is 5. Right? Now, the main mechanism of action. The main mechanism of action for all the copper containing IUCDs is that they inhibit fertilization. That's the best answer. If you do not get this option, then you are going to say that it inhibits implantation. By which method does a copper T never acts? So, if they ask you all of the following are mechanism of action of copper T except, in that except you always have to look for ovulation. Copper T will or any IUCD will never inhibit ovulation. So, the mechanism by which IUCDs do not act is they do not inhibit ovulation. So much so that Mirena, which is a levonorgestrel containing IUCD, still it does not inhibit ovulation. Its main mechanism of action is it leads to endometrial atrophy, and that is how it hinders implantation. Please do not say that the main mechanism of Mirena is that it inhibits ovulation. No, it does not. Right? Now, as far as the chances of PID are concerned, IUCDs, they do not decrease the chances of PID. Rather, the chances of PID are increased within 1 month of inserting the IUCD. So, why within 1 month of insertion of IUCD, the chances of PID are increased, and the most common PID which occurs with insertion of an IUCD is actinomyces. Very, very important, right? Now, the most common side effect of copper IUCD is that it leads to increased bleeding, whereas the most common side effect which leads to removal of a copper IUCD, that is pain. So, if they ask you the most common side effect of copper IUCD, you are going to say increased bleeding. But if they ask you by what is the most common side effect due to which the copper T has to be removed, that is pain. Now, as far as Mirena is concerned, because it is a progesterone containing IUCD, it will lead to irregular bleeding, and as I told you, if you use it for a long time, it leads to endometrial atrophy, and finally it leads to amenorrhea. right? Copper T380A or Paragard again is distributed free of cost by the government of India, and it can be used as an emergency contraceptive. Rather, when I will teach you emergency contraceptive just now, I'll tell you that the most effective emergency contraceptive is Copper T, whereas Mirena, it cannot be used as an emergency contraceptive, right? So this was general things about Copper T and about Mirena. Now there are few terminologies which you have to know. One is the post-placental IUCD insertion. Post-placental IUCD insertion means if the insertion of Copper T is done within 10 minutes of delivery, right? And the postpartum IUCD insertion means if insertion is done within 48 hours of delivery. Now if you do not insert an IUCD within 48 hours of delivery, then you have to wait till 6 weeks, right? And you're going to insert it after 6 weeks. Whenever you are inserting Copper T after 6 weeks, that is called as the interval insertion of IUCDs, right? The interval IUCD insertion, right? Now, next very important thing which you have to remember is, suppose if a patient comes to you with IUCD and she has conceived, right? So if there is pregnancy with IUCD, there are two aspects to this situation. One is what are you going to do with the pregnancy, and the other is what are you going to do with the IUCD. Now, as far as pregnancy is concerned, I'm going to continue her pregnancy unless and until the question tells me that the patient does not want to conceive, or the patient does not want her pregnancy. Till that time, I'm going to say that continue her pregnancy, right? And what am I going to do with the IUCD? If the thread is visible, I'm going to remove the IUCD and tell the patient to continue with her pregnancy, right? But if the thread is not visible, in that case, I'm going to leave the IUCD in situ and I'm going to tell her to continue her pregnancy. But I will also explain to her the risks of pregnancy, so that just in case she wants MTP, I will do that MTP, right? The risks of continuing pregnancy with IUCD are that IUCD leads to increased chances of abortion, number one. Number two, IUCD, it leads to increased chances of infection. So if it is leading to increased chances of infection, obviously infection leads to preterm labor, so it can lead to increased chances of preterm labor, it can lead to increased chances of premature rupture of membranes, and it can lead to increased chances of abruptio placenta. Now, earlier there were some concerns that if IUCD is in place and if a female conceives, right, then there are increased chances of fetal malformations. But then it was seen that if a female conceives with IUCD there, and if she is continuing her pregnancy also with IUCD in place, then the chances of congenital malformations are not increased, right? This is what still William Obbs says. William Guiney, the latest edition, has added just one line, that it may be that in future we detect that yes, the chances of skeletal malformations are raised, but just now studies have not confirmed that, right? Now, this is what you have to remember about IUCDs. Now, one more thing which you have to know about IUCDs is what are the absolute contraindications for IUCD. As I told you that IUCDs, they do not decrease the chances of PID. So, number one contraindication, the absolute contraindication is if a patient has present PID or if she has history of PID in the past 3 months. That's one contraindication. Number two, if there is puerperal sepsis, right? So these two contraindications, they are related to the infection. Number three, if you have to insert IUCD, the uterine cavity should be normal. So if uterine cavity is distorted, again that becomes a contraindication for IUCD. So it is a highly distorted uterine cavity, like it happens in case of congenital malformations of the uterus. 4 and 5 are contraindications which are general contraindications to all the contraceptives, right? Till now we have studied all contraceptives. These two are contraindications, that is pregnancy and undiagnosed vaginal bleeding. So these are contraindications for any type of hormonal contraceptive, right? And also for IUCDs. Now, 6th contraindication which I'm going to tell you, that is specific for Copper T, and that is Wilson disease. And the 7th contraindication which I'm going to tell you is specific for Mirena, and that is if there is history of breast cancer, right? So these are the absolute contraindications for IUCDs, right? So this is what you had to know about IUCDs. Now, one more very important drug which is a non-steroidal drug, right? It's a non-steroidal contraceptive, and this is centroman. The active ingredient in centroman is ormeloxifene, or selective estrogen receptor modulator, right? Now, centroman, what is the mechanism of action? Centroman, it acts by making the endometrium out of phase. That's the mechanism of action. This centroman, it was developed by CDRI Lucknow in 1991, and again a very important point to remember about centroman is that the government of India recently has included centroman also in the National Family Planning Program, and again it is being distributed free of cost in 8 states by the name of Chaya. Right, so DMPA by the name of Antara and centroman by the name of Chaya. Now, the dose of centroman which you have to give is 30 milligrams twice weekly till 3 months. After 3 months, you have to give 30 milligrams weekly, right? The side effect of centroman is it brings about delayed menstruation, right? And centroman, yes, it can be used as an emergency contraceptive. Right? Now, where you were writing about IUCDs, there only just one thing which I want you to mention there is, whenever question says that there is a female with HIV, what is the contraceptive of choice? Now, in a female with HIV, the contraceptive of choice for contraceptive purpose, it is IUCDs, because IUCDs, they have got very low failure rate. And in order to prevent transmission to the partner, you will add a barrier method, right? So, if there is a female with HIV, then the contraceptive of choice is IUCD plus a barrier method. If you have to choose any one between them, then you're going to say it is IUCD, because it's the contraceptive which is going to matter here. And the contraceptive is a contraceptive purpose, we are using IUCD. Barrier method is being used to prevent the transmission to the partner, right? Suppose if the question says there is a female with heart disease, what is the contraceptive of choice? Now, again, in a female with heart disease, in temporary methods, the contraceptive of choice is IUCD, right? Similarly, in female with diabetes, if they ask you, again, it is IUCD, right? But if the question is saying there is a female with decompensated heart disease, now, the moment they've used the word decompensated, that means now the patient's condition is what we have to take into consideration, and then we cannot put an IUCD, because although the risk is very low, still IUCDs can lead to infection, and infection can lead to infective endocarditis, and that risk I'm not going to take if it is a decompensated heart disease, right? So, in decompensated heart disease, if they ask me what is the temporary method of contraception which is best, you are going to say it is the barrier method. And if they ask me in permanent methods, I am going to say that the husband should be advised to undergo vasectomy, right? So, this is the uses of IUCD in different conditions. Clear? Now, let's talk about emergency contraception. Now, what is emergency contraception? Emergency contraception are those drugs which are taken after intercourse, unprotected intercourse has happened, right? Normally, contraception is taken before intercourse. Emergency contraception means that unprotected intercourse has happened and now the female is coming to you for contraception. Now, in case of emergency contraception, all of them, they act best when they are given at less than 72 hours. But yes, you can give them up till 120 hours. Right? The most effective emergency contraceptive is copper IUCD. Copper IUCD can be inserted up till 5 days of unprotected intercourse. That means up till 120 hours of unprotected intercourse. But if your question is, what is the most effective hormonal contraceptive? Now, whenever the question is most effective hormonal contraceptive, please do not say it is levonorgestrel. You are going to say it is ulipristal. Ulipristal is a selective progesterone receptor modulator drug, and the dose, you have to give a single dose of 30 milligrams, right? Apart from being used as emergency contraceptive, ulipristal is also used for managing fibroids. The second answer would be, if ulipristal is not given in the options, then the second answer would be a levonorgestrel. Now, what is the dose of levonorgestrel when you are using it as emergency contraceptive? The dose of levonorgestrel is 1.5 mg. Either you give 1.5 mg stat, or you will give 0.75 mg immediately, and then after 12 hours again you will give 0.75 mg. That's a very, very important question. Now, the other drugs which can be used as emergency contraception are, it is centroman and mifepristone. You can use centroman and mifepristone also as emergency contraceptives. Now, remember the drugs which can never be used as emergency contraceptives. So, whenever they give you a question that all of the following drugs are used as emergency contraceptive except, in that except you will get either misoprost or you will get progesterone only pills, or you are going to get Mirena. Now, the mechanism by which emergency contraceptives act is they interfere with the endometrium and they interfere with implantation, right? And they interfere with fertilization. But what they do not do is they do not interfere with placentation. In other words, emergency contraceptives are not abortifacients. So, they will ask you emergency contraceptives, they act by all of the following methods except. In that except, you will always have they interfere with placentation. Emergency contraceptives are not abortifacients. Depending upon the depending upon what you are using, so if you are using hormonal emergency contraception, then their main mechanism of action would be that they are interfering with ovulation, right? If you are using non-hormonal, like you are using copper IUCDs, then the main mechanism of action will be they are interfering with fertilization, they are interfering with implantation. But never do emergency contraceptives interfere with placentation, right? So that is what you have to remember about emergency contraception. Now, the last thing which I want to tell you in contraception is about the tubectomies, right? Now, as such, tubectomy is taken as a permanent method of contraception, right? Theoretically, it is a permanent method of contraception. So, if they ask you all of the following are reversible methods of contraception except, in that except you are going to look either for tubectomy or vasectomy. You will not say that because recanalization can happen, that is why tubectomy is a reversible method. No. Theoretically, for all our theoretical purpose, tubectomy is a permanent method of permanent method of contraception, right? Another very important question which they ask you is, what are the long acting reversible contraceptives? Now, long acting reversible contraceptives, that is LARC methods, they are three. Number one, implants. Number two, injections. And number three, IUCDs. So, these are the long-acting reversible contraceptives, right? So, now let's talk about tubectomy. Now, tubectomy, you can either do a tubectomy by laparoscopy or you can do a tubectomy by mini laparotomy, right? Now, laparoscopy, one thing what you have to remember is that a laparoscopy, it cannot be done in the immediate postpartum period. Why? Because in the immediate postpartum period, immediately after delivery, where is the uterus? The uterus is just below the level of the umbilicus, right? So, this is where the uterus is present immediately after delivery. Now, if immediately after delivery, I put a laparoscope, I will be puncturing her, perforating her uterus, right? That is why laparoscopy is not done in the immediate postpartum period. Whereas, mini laparotomy means you are giving a small incision and through that small incision, you are taking out the tubes, right? So, mini laparotomy, it can be done in the postpartum period. Now, when you are doing mini laparotomy in the postpartum period, the small incision will be 2 to 3 centimeters below the umbilicus, and through this small incision, I am going to take out the tubes. But if you are doing mini laparotomy in a non-pregnant female, right, or if you are doing it in a female who had delivered 6 weeks back, right, by that time the uterus would have become a pelvic organ, and in that case, if this over here is pubic symphysis, then the incision will be 2 to 3 centimeters above the pubic symphysis, and through that incision I am going to take out the fallopian tubes, right? Now, so there are a few very important questions which they ask you. One question is, what is the most common method of female sterilization? The most common method of female sterilization is laparoscopic tubal ligation. But if they ask you what is the most common method of postpartum sterilization, then you are going to say it is mini laparotomy. By postpartum ligation, it means that you are doing a tubectomy after 48 hours and up till 1 week of delivery. Please be very careful. Postpartum IUCD insertion is up till 48 hours of delivery, right? But postpartum sterilization is after 48 hours and up till 1 week of delivery. If you do not do a sterilization up till 1 week of delivery, then you are going to do it after 6 weeks of delivery, and that is called as interval sterilization, right? Now, what is the site of ligation in tubectomy? The site of ligation in tubectomy is the isthmus, right? And chances of recanalization, they are best if there is isthmo-isthmic anastomosis. What do we mean by that? Suppose a female comes to me for recanalization, that is for reversal of tubectomy. In that case, the chances will be best if while I am making a tube, I am stitching the isthmus part to the isthmic part. Right? So, if there is isthmo-isthmic anastomosis, then the chances of recanalization, that means for reversal of sterilization, it will be the best, right? Now, there is one more method of doing permanent sterilization in females, and that is E-Sure. E-Sure is a coil-like structure, right? This coil is inserted through the vagina by hysteroscopy into the tubes. Now, in which part of the tube do you put E-Sure? You put it in the intramural part of the tube. Tubectomy is done in the isthmic part, but E-Sure is inserted in the intramural part of the tube. Now, this E-Sure, when you insert it in the intramural part, it will start tissue reaction there, and because of that tissue reaction, adhesions will occur and it will lead to tubal blockage. But this tubal blockage is not going to happen immediately when you insert E-Sure, right? So, once you put an E-Sure, you will tell the female that for next 3 months, she is going to use some backup method of contraception. After 3 months, you will do a hysterosalpingography, and then you will make sure that the tubes are blocked. And once you have make sure that the tubes are blocked, then you are going to tell the female that she should stop using any additional method of contraception. Success rate of E-Sure, yes, it's very good. It's 99%, right? Now, when we talk about laparoscopic ligation, right? So, let me show you an image of laparoscopic ligation. Okay, so just now I don't have an image of laparoscopic ligation. So, you will get a somewhat image like this. They will show you a tube and you will see a ring, white ring-like structure which is placed here. Now, this ring-like structure which is placed, this is called as a Fallop ring, right? So, laparoscopic tubal ligation, it can be done with a Fallop ring, which is most commonly used in India, or you can use a Filshie clip, right? Filshie clips, they are not used in India. Now, when you use a Fallop ring, right, then the destruction of the tube is around 3 centimeters of the tube is destroyed. But when you use a Filshie clip, then the destruction of the tube is only 4 to 5 millimeters. Why I am telling you this is, suppose a female comes to me for reversal of sterilization. Now, reversal of sterilization will be good, as I told you, if there is isthmo-isthmic anastomosis. Number 2, reversal will be good if I have used that method for sterilization or that method for tubectomy which had resulted in least damage to the tube, right? The more is the damage to the tube, the lesser are the chances of reversal. The less is the damage to the tube, more are the chances of reversal. Now, because in a Filshie clip, the damage to the tube is hardly 4 to 5 millimeters. That is why chances of reversal are best with a Filshie clip, right? So, if they ask you chances of reversal are best with what method, the chances of reversal are best with a Filshie clip or a clip followed by the Fallop ring. So, Filshie clips, they are more useful in those patients who are young and you know that maybe in future they come to you for reversal. And number 2, Filshie clips are more useful if you are doing a sterilization after abortion, because after abortion the tubes are edematous, right? In that case also Filshie clips are very helpful, right? Now, as far as the methods of open tubal ligation, the mini laparotomy methods are concerned, in mini laparotomy methods, the most commonly used method is a Pomeroy method or a modified Pomeroy's technique. Now, what do you do in Pomeroy's or in modified Pomeroy's technique? Now, in case of Pomeroy technique, first I am telling you Pomeroy and then I will tell you modified Pomeroy. In Pomeroy's technique, you will make a loop of the tube like this. Now, this loop is going to be present at the at the junction of proximal 1/3 and middle 1/3. You are going to make a loop, right? And then you are going to tie a single catgut, right? You are going to tie an absorbable suture, that is a single catgut suture. The single ligature is done, and then this part of the loop is cut, right? This is what is Pomeroy's technique. Why we are using an absorbable suture is because once the suture gets absorbed, this is how the tubes will appear like, right? And over here there will be the mesosalpinx like this, right? So the tubes with the two ends of the tubes will get separated. This is what is Pomeroy's technique. In modified Pomeroy's technique, so this is the tube, everything you make the loop same way. Over here, this over here is the mesosalpinx, right? Now, in case of modified Pomeroy's, I have to do a double ligature, right, like this. Now, if I have to do a double ligature, I will have to make a window in the serosa, right? I will make a window in the serosa, I will do a double ligature, and then this part of the tube, the loop, I am going to cut and I am going to send it for histopathological examination. This is called as modified Pomeroy's technique, where you are doing a double ligature, right? Now, why am I sending it for histopathological examination? That is because at the cornua of the uterus, there are three very important structures attached, right? And from anterior to posterior, they are RTO, round ligament, the tubes and the ovarian ligaments, right? So, because three tube-like structures are present there, that is why in order to be sure that it is the tubes which I have cut, I am going to send it for histopathological examination. And this is the reason why, because three tube-like structures are present there. If they ask you what is the most common cause for failure of female sterilization, you are going to say it's identification of the wrong structure. And also one very important precaution is that when you are doing tubectomy, in order to recognize the tube, you are going to recognize the tube from the fimbrial end. You are going to trace the tube backwards from the fimbrial end, because fimbria are present only in the tube. They are not present in the round ligament. They are not present in the ovarian ligament, right? So this was Pomeroy's and modified Pomeroy's. Modified Pomeroy's in some places is also referred to as Parkland technique. Right? Now, there are certain other techniques which we will quickly go through. We have a Madlener's technique. Now, in Madlener's technique, what you do is, everything is same. You are going to tie a single ligature here, and instead of cutting the tube, you are just crushing the tube, right? You are not cutting the loop, you are just crushing the tube, right? And that is why Madlener's technique, it has got high failure rates and it is no longer practiced, right? So in Madlener technique, just one thing, you have to crush the tube, you don't have to cut the tube, and that is why it has high failure rates, no longer used, right? Then the other technique which is there is the Irving's technique. Now in Irving's technique, what you do is, you are going to take the loop or a part of the tube out, and from the isthmo-ampullary junction, you are going to cut the tube, right? So you will cut the tube from the isthmo-ampullary junction. After cutting the tube, the proximal part of the tube, you will make a tunnel in the myometrium of the uterus, and you will put the proximal part of the tube in the myometrium. And the distal part of the tube, you are going to stitch it. See over here, they have stitched it with the serosa, right? So you are going to stitch the distal part of the tube with the serosa in a pursing manner, whereas the proximal part of the tube will be put in the myometrium of the uterus. You will make a tunnel in the myometrium and you will put the proximal part. This is called as the Irving's method, right? Then There is one more method, which is the Uchida method. This Uchida method, although it's a little complex, but it has got very less failure rate, right? Now, in Uchida method, what I'm going to do is I am going to take injection of normal saline and epinephrine, and I am going to put it in the mesentery here, right? So that the mesentery of the serosa of the tube, it will swell. Now, once the serosa has swollen, I'm going to take the tube out and I'm going to cut the tube. So, the second step what I have done here is I have cut the tube. Now, what am I going to do? Now, what I am going to do is the proximal part of the tube, I am going to just tie it and I'm going to leave it in the serosa. Just tie it and leave it in the serosa. It will retract backwards, right? And the distal part of the tube, you are stitching it with the serosa in a purse string manner. So, in Irving's, the proximal part was put in a tunnel of myometrium, the distal part was stitched. Here, you are stitching the proximal part, you are going to just leave it, right, tie it and leave it, and the distal part you are stitching it in a purse string manner. Uchida method has got the lowest failure rates, followed by the Irving's method, right? Then, and the last method is you can go for Kroner's fimbrectomy. In Kroner's fimbrectomy, as the name suggests, you have to cut the fimbria, but before cutting the fimbria, you are going to do a double ligation. Doubly ligate the fimbria and then cut the fimbria. That is called as Kroner's fimbrectomy. So, these are all the methods of tubectomy, and that is all what you have to know about tubectomy. About vasectomy, you have to know that these days we are doing the non-scalpel vasectomy and you are going to take out the vas deferens. You are not going to give any cut on the scrotum. You are going to use a fixation clamp and you are going to use a dissecting clamp, right? So, there is a instrument, a ring shaped instrument which you are going to use, that is a ringed clamp which is used for fixing the vas deferens, and for making an opening in the skin you are using a dissecting forceps. That's the only two instruments which you use in case of the non-scalpel vasectomy. And then you are going to cut the vas deferens and you are going to tie both the ends and you are going to leave them inside. Now, when you do a non-scalpel vasectomy, you are going to tell the patient that till 15 to 20 ejaculates. In other words, for 3 months, patient has to use some additional backup method of contraception. After 3 months, you are going to do semen analysis, and once the semen analysis reports confirms that there is azoospermia, then you are going to tell them not to use any contraceptive method, right? Then, if they ask you what is the most effective method of contraception, you are going to say that the most effective method of contraception is an implant, are implants, and the implant which is used these days is Implanon. So, this over here is an implant, right? Earlier we had a 6-rod implant which was called as a Norplant. Norplant is no longer used. Nowadays we have a single rod implant, and the single rod implant is called as Implanon. This Implanon is 4 centimeters in length and it has got progesterone. It is a progesterone only containing contraceptive. The progesterone which Implanon has got is etonorgestrel, and the total amount of etonorgestrel is 68 milligrams, and it will release around 67 micrograms of etonorgestrel per day. Implanons, the lifespan of Implanon is 3 years. Right, and it has the minimum failure rate. The failure rate of Implanon is 0.05, right? Now, Implanon, it was not radio opaque. These days, a radio opaque version of Implanon is visible, which is Nexplanon, right? So, there is no difference between the composition and between the lifespan of Implanon and Nexplanon. The only difference is that Nexplanon is radio opaque, Implanon was not radio opaque. Now, again, because it is a progesterone only containing contraceptives, everything what I told you about progesterone only contraceptive holds true for this also. So, because it has got 68 milligrams of etonorgestrel, so its main mechanism of action will be it will inhibit ovulation, right? And its side effect will be, yes, it is going to bring about irregular bleeding, and ultimately it is going to lead to amenorrhea. right? So a very important point about Implanon is that it is better than DMPA. Why it is better than DMPA? Because DMPA was decreasing the bone mineral density, but Implanon, it does not decrease the bone mineral density, right? So that is what you have to remember about Implanon. Now, there are certain failure rates which you have to remember. For vasectomy, the failure rate is 0.1%. For Implanon, I told you it is 0.05%. That's the best or the most effective contraceptive, right? For tubectomy, the failure rate is 0.5%. For Mirena, the failure rate is 0.2%, and for copper T, it is 0.6%. As far as OCPs are concerned, you have a range. 0.3% is in case of perfect use. If the female is using it perfectly, it is 0.3. In case of typical use, the failure rate is 8%. Right, so between from 0.3 to 8% is the failure rate of oral contraceptive pills. Now, as far as the efficacy of the contraceptive is concerned, you use Pearl Index for calculating the efficacy of the contraceptive. Now, how do you calculate the Pearl Index for a contraceptive? So, suppose there is a contraceptive X, right, which was used by 100 females. Right, and out of those 100 females, 24 females became pregnant over a period of 3 years. And they ask you that tell the Pearl Index of this contraceptive. So what you have to remember is that Pearl Index, there are two formulas for Pearl Index, a formula A and a formula B. Formula A says the number of accidental pregnancies which have occurred divided by the total number of females. Sorry, I'll write it a little clearly. Total number of females who have used that contraceptive and for the number of years they have used it multiplied by 100. Right, multiplied by 100. That is formula 1. Formula B is the same formula, that is the number of accidental pregnancies upon the number of females who have used it into the months for which they have used. Now, the moment you use number of months, now in formula A, if you had to convert years to months, you would have multiplied it by 12. And we all know that maths say if you are multiplying denominator by 12, you should also multiply the numerator by 12, right? So the formula for months becomes that instead of multiplying it by 100, you are going to use 1200 to multiply it, right? So please be very careful about which formula you are using. If you are using years for which a female has used that contraceptive, the multiplicative factor is 100. But if you are using the months for which a female has used that contraceptive, then the multiplicative factor becomes 1200. So let's see our question quickly. Question is saying the number of accidental pregnancies. First, I am using formula 1. 24 females are using it, right? 24 females, they became pregnant. 100 females were using this method. They used it for 3 years, right? And the multiplicative factor is 100. So 100 cancelled, 3 ones are 8, 3 8s are 24, right? So here the Pearl Index becomes 8. Now, if I use formula B, the number of accidental pregnancies are 24, the number of females who have used it are 100. For how many months they have used it? They have used it for 3 years, which means they have used it for 36 months. And now I have to multiply it by 1200, right? So 12 ones are, 12 threes are, 3 ones are, 3 8s are. So the Pearl Index by using either of these two methods is 8. The only thing what you have to remember, when you are using years, the multiplicative factor is 100. When you are using months, then the multiplicative factor is 1200, right? So this is all what I wanted you to know as a booster in Obs and Gynae. Now, apart from this booster, you are also going to listen to the CTG and the partogram lecture which I have given on Marrow, and you are also going to listen to the image-based discussion in Obs and Gynae, which I have done in Marrow, right? Go home now and, no, you are sitting at home. Now you are going to, for another 3 days, you are going to do only Obs and Gynae with this booster and all the updates and with image-based discussion and with your notes, right? Everything in Obs and Gynae is complete. Right, so these 3 days, please revise Obs and Gynae. Any questions which you have on Obs and Gynae, I know I am not a person who replies very quickly to your queries, but yes, now I am going to reply, and I am creating a Telegram group where you can ask me all the queries on Obs and Gynae. I am not going to answer queries on all the groups, right? It becomes very difficult for me. So the Telegram group which I am going to make is GSOG Group 2019.